Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so pleased to have you joining us today for our symposium on tackling structural racism in health. The symposium occurs in conjunction with the release of the October 2023 issue of Health Affairs devoted entirely to the topic. It follows on our successful issue on racism in health, released in February of 2022, expanding on the literature, on the scholarship, and our understanding of these critical issues. Health Affairs is much more than a journal, and so although we're so thrilled to be able to release the issue, we want you to be aware that there are many components. In addition to the 19 papers in the issue, including some commentaries and perspectives and narrative matters essays, including a poem that you'll hear today. We've also published 15 articles in Forefront since January. We have a new video, a conversation with some leaders in the structural racism area. 8 of our papers are released along with video abstracts. We have artwork from Sagetopia, an interactive photo gallery of Baltimore voices associated with one of the journal articles. We have 3 events, not just this one, but 2 others, and co-sponsoring one with the Leonard Davis Institute at Penn. 5 of the episodes of A Health Podyssey will feature authors from this issue, and 1 episode of this week will discuss the issue as well. So we just have a tremendous amount that we're thrilled to be able to share with all of you. I want to give you a sense of what the next few hours will be like. In a moment, I will introduce Dr. Simbo Ige, Managing Director of Programs at the Robert Wood Johnson Foundation, who will make some opening remarks. As mentioned, you'll then hear the poem that was published in the issue. We'll then turn to an opening panel, which will include leaders discussing structural racism in health and how to tackle it. And then we'll move into 4 panels that will be the authors of papers in the issue, presenting their papers and discussing them and answering questions as you might have them. In case you want to engage with any of the other items, then in addition to the symposium, go to the landing page for the issue, healthaffairs.org/racism-and-health, and you will see links to everything that I've mentioned. Definitely want to note the support that we receive to make this issue possible. It takes a tremendous amount of work to do. So we're grateful to the Robert Wood Johnson Foundation, the California Wellness Foundation, and the Episcopal Health Foundation for their financial support. And I will introduce them again in a moment for a panel, but I want to acknowledge our theme advisors, Rakaya Yerby and Gilbert Gee, who navigated the issue with us, and our assigned editor, Jessica Bylander, who managed the issue. It takes a very large team to make this happen, and it's so great to see it all come together at this point. I will mention, if you're watching us live, you do have the opportunity to put questions in the Q&A box down at the bottom of your screen. We have a very tight agenda. I don't want to overpromise here. The odds that we can bring those questions into the conversation are not 100%. But if you have a topic you'd like to bring up, please put it in. And particularly when it comes to the papers, if you have a question about a specific paper that you'd like answered, those sessions tend to have room for that kind of Q&A. With no further ado, again, just with your appreciation for joining us today, I'm pleased to introduce Dr. Simbo Ige, Managing Director of Programs at the Robert Wood Johnson Foundation. Before coming to RWJ in January, Dr. Ige was Assistant Commissioner of the Center for Health and Community Wellness in the New York City Department of Health and Mental Hygiene. Public health physician, Dr. Ige has also been the Executive Director of Global Health at the United Methodist Church Global Ministries and the United States Agency for International Development, USAID. Dr. Ige, thank you for being here and for kicking us off with some opening remarks.
Well, thank you, Alan, and I am so excited to be a part of this event. Good afternoon, everyone. As many people know, the Robert Wood Johnson Foundation is committed to building a culture of health. And that vision requires people working together to dismantle structural racism and other barriers. And that is so that everyone has the chance to live the healthiest life possible. We know that this will take time and it requires enormous collective effort. But this month's issue of Health Affairs marks an important step in the right direction. The Foundation has recognized the necessity of increasing health equity for many decades. Our focus has, however, become much sharper in the recent years. Documenting disparities has been an important research for years, and the Foundation has led a lot of that work. But it is not enough. We cannot just document differences and outcomes and hope that that will lead to change. While many people face barriers to health, we know for certain that Black and Brown people confront more challenges that are deeply rooted. There are racist policies and structures that intensify every other form of discrimination and intersect with the social conditions that affect health. And so we need to more urgently pinpoint the causes of these disparities, and that is the racism. Whether it is knowingly or unknowingly, it is woven into healthcare systems, into policies and practices. But the question is, how do we best illuminate these causes? We need different and new approaches to research, not just the usual randomized controlled trial. I am a Black woman and an immigrant, and I know that racism in America is sometimes subtle. It is so subtle, sometimes you might question whether you're imagining it. Sometimes I wrestle with, is it really this difficult to get accepted into a co-op apartment building? And sometimes I wonder if my colleague questions my treatment plan, or will they question my treatment plan if I were a white male doctor? The subtlety is real, it is insidious, and it is challenging to fight. But similar to the Me Too movement, looking at this incident from the individual level does not always provide the full picture. But when we back out, the scale of the problem becomes clear as day. We cannot improve health in the United States if everyone doesn't have an equal opportunity. And we will never achieve the vision of a national culture of health if we don't openly acknowledge and address the impact of structural racism on health and healthcare systems. We know the causes are complex and they're deeply rooted. And I want to be very clear. The individuals and institutions upholding the systems, the policies and practices that have led to the worst outcomes for health for Black people and Brown people often do not realize their role or what change is required. But that is not an excuse for inaction. We don't have to know all the answers before we start thinking about how we attack the problem. Look at COVID-19. Almost overnight, the pandemic made us approach public health differently and address it as an urgent shared challenge. The public health and healthcare community work together, but we also involve the whole community. Faith leaders, media, community health workers, nonprofit organizations, the federal, state, and local government, everyone rallied. Everyone not only had a seat at the table, but a meaningful role to play. That table became our table, all of us in it together. The United States can enjoy periods of amazing social solidarity, but to harness it and benefit from it, we need to feel shared responsibility. We need to work together. It's not just the hospital's health system or the government's health system. It is all of ours. The system includes all of us. And in that spirit, early next year, the Robert Wood Johnson Foundation will be launching an initiative called the Intersection. It's where anti-racism and healthcare meet. The Intersection is going to be a network. It will bring people together working to build anti-racist systems, advocates, healthcare leaders, public health workers. And together we will share insight and successes on the road to making change. We don't have all the answers, but we know the conversation needs to happen and we feel shared responsibility. I want you to join me in watching a short video.
We all want to live in a United States where everyone has a fair and just opportunity to reach their best health, no matter their race, ethnicity, or income.
But visible and invisible barriers create unequal opportunities for health in this country. They are the result of racist practices and policies in our healthcare system that place more value on some lives than others.
Like birth inequities, income inequality, inadequate pain management, cultural insensitivity, COVID-19 deaths, few providers of color, lack of representation of darker skin tones in medical textbooks, lack of representation in research, the list goes on.
It feels overwhelming, but we can build an anti-racist healthcare system and begin to remove these barriers. It will take a new approach, one where advocates, patients, and hospitals collaborate to identify barriers and make systemic changes.
This is already happening in some communities where partnerships, both formal and informal, are being forged in public and behind the scenes.
It's hard, messy, and often emotional work, but together real changes are being made that remove barriers and improve health. This work is possible, and when progress is made, it needs to be celebrated, supported, and spread.
That's what will happen at The Intersection. The Intersection is where healthcare and anti-racism meet. Supported by the Robert Wood Johnson Foundation, The Intersection is a space for people to hold meaningful conversations, share insights, and learn from each other to improve health for all. It's where we all share how to work better together.
Together, we will knock down barriers so that all have a clearer path to health.
And I hope you can learn more about this initiative at the website that will be shared soon. I am looking forward to hearing from many of the researchers who contributed to this month's issue. And today we celebrate your learnings while acknowledging that much work remains ahead. Please know that we are with you for the long haul, all of us together. And again, thank you, Alan, for this opportunity.
Thank you, Dr. Ye, for those remarks and for launching what sounds like will be an important new initiative. I look forward to seeing how that takes shape. As we move to the next part of the program, it seems our poet has not arrived, and so we're going to try to squeeze him in later if he returns. I do want everyone in the audience, because we've received a number of questions, to know this program is being recorded and will be posted on our website. It takes a couple of days, usually after we complete this session. And I also want to note that through part of the generosity of the funding organizations, all of the articles are open to all in the issue. So there's no paywall for this issue due to foundation support. With that, it's my pleasure to move us directly into our first panel. Let me begin by introducing our panelists. They are Dr. Gilbert Gee, Professor and Chair of the Department of Community Health Services Sciences at the Fielding School of Public Health at UCLA, and Rakaya Yerby, Kara J. Trott, Professor in Health Law, Moritz College of Law at Ohio State University. Gilbert and Rakaya were the theme issue advisors. That means they shepherded this through from the very beginning: conception, solicitation of abstracts, selection of abstracts, review of papers. We truly could not have done this without you, and we appreciate all you did to make this possible. Joe Betancourt is the president of the Commonwealth Fund, and Sandro Galea is the Robert A. Knox Professor and Dean at Boston University School of Public Health. It's my pleasure to be able to have a conversation with the four of you about quite a few topics that will touch on different dimensions of tackling racism in health. So as we begin, I've asked each of my panelists just to make a few opening remarks, a few minutes of their own thoughts on the topic. Joe, I'm going to turn first to you with your experience, of course, now at the Commonwealth Fund, but many years leading organizational change within the health system.
Great. So thank you so much, Alan. Appreciate the kind introduction, and congratulations on your and Health Affairs leadership here, and certainly the team, as well as the editors who I think produced a fantastic set of papers that will really add to this discourse. So congratulations to the authors as well. So let me just say I'm honored to be here. I'm appreciative of the foundations that have provided support to this. And I just perhaps begin with a bit of a long view, given my career, particularly focused on disparities in healthcare, and really talk about a couple of chapters going back now as we celebrate Unequal Treatment's 20th anniversary. So I had the honor and privilege in 2003 to be part of a study committee that released the Institute of Medicine report, Unequal Treatment, that added to, I think, a long history, some well acknowledged and well written about in the scholarly literature, others acutely felt by many across our nation, that documented significant disparities in healthcare, the treatment that patients were receiving within the healthcare system. I think many of us feel that that was a seminal report, again, not the first, certainly not the last, but one that brought the imprimatur of the IOM to this discussion. And so I want to begin with that chapter, because I'd say a couple of things. First, that group acknowledged that racism played a role in disparities in healthcare, but it also talked about the very important contributions, very large contributions of the social drivers of health and of access to care. But we really zoomed in on disparities in healthcare, and then I embarked on a career, as did many, on trying to advance this work. So, Alan, I'd say as we think about this work and its evolution, the first chapter was one really that I'd call the early adopter phase. So IOM was released in 2003. Within a couple of years there, you had progressive leaders, early adopters, organizations that felt like if the Institute of Medicine said there were disparities in healthcare, they exist, and we should get about the work of better identifying and addressing them. So there was a lot of barnstorming there, and it was particularly focused on data. I think it really tried to link on to the Institute of Medicine report, Crossing the Quality Chasm, that centered equity as a key principle of quality. But I would say the discussion of racism and structural racism was fairly low in the background as the drive was really around quality of care. That chapter, I think, evolved within a few years as the conversations of healthcare reform evolved and the buzz around the Affordable Care Act. I'd say that while incredibly exciting, and while we knew that improving access would absolutely help us address disparities in healthcare, what it began to do was decrease a little bit of the attention that was focused on disparities in healthcare, place more attention on the social drivers, which we acknowledge was important. But I would say that second chapter was one that was really defined by greater attention to access and less attention particularly to equity and quality. That chapter was followed by a third chapter after the Affordable Care Act, which is this push towards value and payment reform. So that push is one where we begin to say we are no longer going to pay for healthcare services for the quantity of them, for the quality of them, team-based care. We think about the accountable care organizations, and that allowed for us to begin to talk about disparities, racial ethnic disparities, as being a high-value target as we pursue value in healthcare. Very, very exciting. And then, Alan, that morphs to chapter 4, which is the murder of George Floyd and the incredible reckoning that our nation undergoes yet again on racism, structural racism, and racism in healthcare. So, of course, for people like me and others who care deeply about this, this was an opportunity to grab a lot of ground and really advance this work with that acknowledgement and that window of opportunity. And I think we made a lot of progress during that phase. Several papers that document that. We have a paper today that'll talk a bit about the evolution and expansion of chief health equity officers and the like, but ultimately a lot of progress made in that space. And then I'd say, Alan, we're in a new chapter today, which is one, quite frankly, of resistance, one where we need to be persistent in discussing how, yes, racism plays a role, yes, it's quality, safety, value, but that disparities in healthcare and the social drivers and access are the three-legged stool that are going to get us to eliminating disparities in health outcomes. And so it's an exciting time. I think this is an absolutely fantastic contribution. We're moving beyond just collecting data and performance measurement, although I'd say that's still not done at scale. We need to go farther in that realm. But yes, we need to move towards solutions. And I think this edition of Health Affairs begins to add to that launching from 18 months ago and launching from when I worked with you many, many years ago on an effort in health affairs around health equity. So I'm appreciative. I think it's exciting, and I'd love to hear more from my colleagues as well, who I'm very honored to be with today. Thank you, Alan.
Thank you, Joe. Just to say, first of all, an incredible tour of the last 2 decades, done very succinctly and with great organization. I appreciate you mentioning you were our theme advisor on a health equity issue about 7 years ago, and so it's nice to have you back in this spot again. I'm going to turn next to Sandra Galea. You, of course, a leader in the public health community. We often hear that racism is a public health crisis, and be interesting, I think, for us to come at this from the public health side in addition to the healthcare system side that Joe just described.
Well, first of all, thank you, Dr. Weil. I'm honored to be here. Congratulations to you, to Drs. G and Dr. Yerby for the special issue, which I think is really terrific. In a limited time, I just want to make 3 points, which hopefully are helpful in advancing the conversation. My first point is, actually, Dr. Ige prefaced it quite nicely in their comments. In the past 20, 25 years, in parallel with the evolution of our thinking on this that Dr. Betancourt described so well, there has been a reanimation of our understanding in health of the centrality and of social and economic factors in determining health. And I think in the past decade, maybe accelerated in the past 5 years, we have come to realize that structural racism is not only one of those social factors, but it is intersecting with and shapes all those social factors. Now, the reason it's actually important to say that is because these social factors, structural racism among them, are ubiquitous. And that means that unless we tend to it, we are never going to improve downstream health sufficiently. By way of illustration, because sometimes perhaps it's helpful, if there is an epidemic of asthma, if there's an increase in asthma, we can keep prescribing more and more inhalers, but unless we actually deal with air pollution, we are never going to reduce the population prevalence of asthma. By way of another illustration, if we have an increase in cardiovascular disease, we can keep prescribing statins and we can keep doing more surgery, but unless we deal with saturated fats that are prevalent in the diet, we're never going to make a successful impact on cardiovascular disease. Similarly, once one understands that structural racism is ubiquitous, as I said, Alan, as you mentioned, many papers, and especially as you mentioned, Dr. Ige did a very nice job of summarizing, I thought, we are never going to deal with all the downstream consequences of structural racism. And I think this is an important point. It's a methodological point, in some respects, a bit of a geeky point, but I think it has implications for everything else we do, because it says that dealing with these ubiquitous factors is non-discretionary. It is not good enough to say, one could say, okay, structural racism is an issue, but you know what? If we develop enough medicines, we're going to deal with inequities in maternal mortality and infant mortality. Well, the science actually shows that's not true, that unless you deal with these ubiquitous factors, structural racism first among them, we're never going to achieve health equity. So I think what this issue does, and what this agenda does as we think about it going forward, is it makes structural racism very much a concern of anybody who's interested in health. So that's point A. Point B, then is the question of what implications does this have for policymakers? And, there are some papers in the special issue who talk about racism-conscious approaches to policymaking. And I actually think that term is quite a useful term, because what it means is that policymaking needs to keep in mind these ubiquitous factors. Again, I go back to my analogy about air pollution. It's you can come up with all sorts of policies that are trying to tackle and help the individual with asthma, but unless the policies are aware of the preponderance of air pollution in particular neighborhoods, you're never going to reduce the prevalence of asthma. And similarly, any policymaking needs to keep in mind this ubiquitous factor that has really characterized all of health in this country for hundreds of years. We are never going to really get to a point where we want to get to. If we are going to say that we would like to close health gaps so that, as per the video Dr. Ige showed, everybody has the same opportunity to live a healthy, long life without differentiation based on identity, based on racial identity, we have no choice but to tackle structural racism. And then my final point is, because I'm always thinking when I think of scholarship like this about the implications for the next generation, I think we are at a place where we cannot teach population health science principles, the practice of public health, without embedding within it the centrality of structural racism as one of the core ubiquitous forces that shapes health. And that is a different way of teaching and learning. That is a way of teaching and learning that is actually different than the way public health has taught, certainly the way public health used to teach 10 years ago, 20 years ago. So I do think that this is an evolution in our understanding. It's an evolution in understanding, and it's a convergence between, I think, moral arguments that many in the field have made for a long time, and also scientific arguments that are beginning to converge towards showing us that this needs to be at the core of how we teach and how we think going forward. I'll stop there.
Thank you so much. It's really interesting for me to hear the weaving and the commonalities and the differences in the language used in the public health community and the health services community. We'll continue that theme through our discussion. I want to turn to the lawyer on the panel, other than me as moderator, but I don't pretend to have the legal knowledge in this field. Professor Yerby, help us understand the role of law both in creating some of the structural racism that we see and potentially dismantling.
Yes, law can be both a tool to perpetuate structural racism and a remedy to address structural racism. In terms of a remedy, we see Title VI of the Civil Rights Act of 1964, which prohibits racial discrimination by healthcare institutions receiving federal funds such as Medicare and Medicaid. Title VI was an outgrowth of a lawsuit brought by Black physicians and patients to challenge the denial of care by North Carolina, a hospital receiving federal funds. And we need to continue this legacy of using law, particularly Title VI and Section 1557 of the Affordable Care Act, to challenge structural racism, which is one form of governmentally sponsored racial discrimination in the healthcare system. Examples of governmentally sponsored racial discrimination in health, many of which are discussed in articles in this issue, which is such an honor to be a part of. These examples include the continuing use of race-based medicine and clinical algorithms, the failure to adopt institutional policies to limit implicit bias that has been shown to limit racial and ethnic minorities' equal access to medical care, healthcare professional education that trains individuals about biological differences, such as a higher pain tolerance of Black individuals, the underpayment of healthcare workers, especially community health workers and home health workers, which are disproportionately racial and ethnic minority individuals and women, and the lower payments paid to them by Medicare and Medicaid, lower reimbursements for Medicaid providers that traditionally provide care to racial and ethnic minority individuals, and the ways that race and disability show up in death certificates as a cause of death in natural disasters and police custody, discussed in the work of legal scholar Brittany Wilson. We need to work towards health justice, which is achieved when discrimination, including structural racism, is eliminated, and minority groups have the power to develop solutions to achieve health equity for their communities. To achieve health justice, law should be used to facilitate community-driven structural change, to eliminate structural racism, and provide financial supports and accommodations, including reparations to repair the generational harm caused by structural racism. These legal responses are still appropriate, even after the Supreme Court decision regarding affirmative action and prioritizing COVID-19 treatments, because the Supreme Court reaffirmed the responsibility of governmental action to address and eliminate governmentally sponsored racial discrimination, thus allowing for racism-conscious measures to eliminate structural racism. I want to thank Alan and Dr. G for their work on this issue. I'm so excited to be here and talk more about the ways that law could be used to eliminate structural racism and achieve health equity. Thank you. Health justice. Thanks.
That's good, and we should note that last word slip because it is both equity and justice, and we should talk about the importance of both of those. And maybe we'll have a moment to, but I do want to bring in Dr. Gee. You, as one of our advisors, have looked at this. I think, although you practice sort of in the public health space, I think you've looked at some of the interactions between the health sector delivery systems and public health. And I wondered if I could turn to you next for some opening comments.
Thank you. Yes, I'm so honored to be part of this amazing group of authors and collaborators, and just congratulations to everybody for such a wonderful issue. Our three speakers discussed three of the major institutions that work to improve health and well-being. Of course, they are the legal, public health, and medical system. These systems are obviously intertwined. The medical system takes care of us when we're sick. The public health system prevents us from being sick. And the legal system provides the rules by which these systems operate and the remedies for action when the systems falter. And yet we know that these are just a subset of the many systems that collude to shape the health of our people. The types of systems that we interact with change over the life course. When we're young, the predominant systems include those related to education, foster care, juvenile justice. And as we get older, we come into contact with new institutions, such as those related to work and insurance. And with each new institution comes the opportunity to encounter racism. Racism can occur from the justice system, the healthcare, the legal, the insurance system, and so on. And we've enacted programs to eradicate racism within specific institutions. And so, for example, we call upon medical schools to change their curriculum so that students can learn about cultural and structural competencies and to increase the pipeline of practitioners and leaders of color. Simultaneously, in other spaces, we might call upon the elimination of school resource officers. We might talk about defunding the police and making other changes to the systems of law enforcement. Yet, past interventions that focus on one institution at a time have largely not led to durable changes. For example, in the decade after 1965, we saw marked reductions in Black-white disparities in outcomes like infant mortality rates. And this was largely due to desegregation of hospitals. Unfortunately, those changes soon reversed in the decade after. And seeing things like this, Derek Bell lamented, even these Herculean efforts we hail as successful will produce no more than temporary peaks of progress, short-lived victories that slide into irrelevance as racial patterns adapt in ways that maintain white dominance. These adaptations we have called the new Jim Crow, modern racism, and racism reinvented. And so, although we've made changes to outlaw housing discrimination, the work of segregating people of color merely shifted from the housing system to the penal system in the form of mass incarceration. So the problem is that changes to one system by itself neglects to consider that institutions are connected together. So institutional racism refers to that perpetuated by individual institutions like medicine or education, where structural racism refers to how these institutions collaborate together to uphold white power. As an example, recent research has shown that the death certificates of Black people who died in police custody were coded by coroners as due to sickle cell disease, despite evidence of traumatic injury. And so certainly a lot more research needs to be done, in this space. But what this is really saying is that the coroners help provide cover for police transgressions. And the general principle here is that the ideas are consistent with the view of structural racism as arising from the collaboration of multiple institutions to uphold racial inequities. So going forward, we need to think about interventions that address multiple systems simultaneously and their interconnections. Thus, we can't simply intervene on medicine in isolation or law in isolation. Our biggest challenge will be to understand how multiple systems conspire together to create such inequity. And certainly the field is moving in that direction. And in fact, a report that's soon forthcoming from the National Academy of Medicine will be talking about how these various systems, like the legal, health, and economic systems, join together to create these inequities. So fundamentally, our society's equilibrium is one of inequality. It's a homeostasis of racial harm. And to fix this, we need to focus on these interconnections across institutions so that we can change the narrative and foster an equilibrium of equity. Thank you.
Thank you for those thoughts and for setting the stage for what will be a little time we have here for a conversation. Here's how I'd like to start as I bring you all in. It's been 18 months since our first issue on racism in health, and I feel like even just in those 18 months, there's been an evolution. And Joe, you mentioned some of this in your comments. there's been a longstanding effort to document disparities and unequal treatment, and that needs to always be done. But it does feel to me like there's been a shift in the direction of actually some of the cross-system approaches, Gilbert, that you just mentioned. I want to bring a specific topic in that's also come up, which is the role of social factors, or sometimes called social determinants of health, as both a way to illuminate some of the structural racism, but in my mind, it also sometimes impedes our ability to focus on racism, because people just sort of deconstruct racism into social things like housing and education as opposed to racism. So I wonder, again, it's pretty broad, but I'd love to hear the thoughts that any of you have on where we are in the evolution of our scholarship, our thinking, our knowledge, and our actions to move sort of head on, viewing racism as a factor in conjunction with other social factors, but as one that requires focus on its own.
That's a great question. I would just say that is the work that I tried to do when I revised the social determinants of health framework, to actually put in structural discrimination and structural racism as the main root cause, with law being a tool to perpetuate that. And so what that means is that our views of oppression and inferiority that we try to use to create a racial hierarchy where whites are at the top and usually blacks are at the bottom is impacting our systems, right? So that impacts, can individuals who are racial and ethnic minorities get access to equal housing, to equal COVID-19 treatment? Can they get access to high wage jobs? And that all impacts health and well-being. So for me, I think where we are moving is that people are beginning to recognize that structural racism is one of the root causes of inequalities in our systems that have been associated with poor health outcomes for racial and ethnic minorities. But one thing I do want to highlight, I know this issue is focused on structural racism, that all of us have seen more discussion about the intersection of other identities, and whether it's disability, women, trans, that overlap is important to recognize, as well as discrimination and oppression keep individuals who are Black, trans, disabled individuals from getting access to healthcare. So I'm excited about the movement in the last 18 months to recognize that structural racism is a root cause of health inequities.
Sandra.
I mean, I agree with Professor Yerby. I suppose it's a glass half full, glass half empty. I'll start with Professor Yerby's last part of the comments, which is the glass half full side, which actually that we've come a long way, and these conversations are now happening. And Alan, as you said, this is the second special issue of health affairs. So does the glass half full? The glass half empty is structural racism has been a foundational driver of all of health in this country for 400 years, and it's only the second health affairs special issue about this issue. So it depends on your perspective. I mean, Dr. Betancourt mentioned earlier about the inflection point around the let's call it the racial justice consensus in the academic political media spaces, and that's a real advance. You also mentioned, Alan, earlier, a number of cities declaring racism a public health crisis. Many of us had been writing about that for about a decade to 2 decades. So I prefer to lean into hope that actually we are doing better. One can always say what took us so long, but the truth is the world evolves slowly and sometimes discontinuously. And I think we're at a point where there's been an inflection in our thinking about these issues, which is to the positive.
Joe?
Yeah, happy to add here quickly. I'd say a couple of things. I mean, we have talked always about the social drivers, access, and healthcare, in addition to other factors, but those three big groups as being the kind of key formula that would help us eliminate disparities in health. I'd say second, we always placed the discussions around structural racism within that social context and really tried to make the point that, nobody chooses to live on the other side of the tracks, that the social drivers that we discussed today are in fact the result of a lot of very deliberate, kind of well-documented historic policy decisions. And so I think that's critical. I'd say we've advanced in a lot of ways, Alan. I think, the understanding and investments, even measurement of social needs is grown incredibly over the last few years. I'd say second, the science that has fundamentally placed racism and its physiologic impact on weathering and premature hypertension and diabetes has advanced a whole different conversation as well over the years, not to mention the tens of thousands of papers now that document in very carefully controlled studies that, yes, people are treated differently based on their race. And so that irrefutable evidence now, perhaps denied when there was only 5,000 papers, now I think proved clearly. And, we factor in racism as a series of key factors, but one that is central to all efforts here. And I think that's been the progress we've seen. I'll end by saying that, yes, we are seeing really important actions by CMS that I think fundamentally will help advance this work, by payers. And I think after 20 some odd years of this work, I think that's what it will take. This needs to move from a nice to do to need to do. And I think we're getting to that place where we will hopefully see that next inflection point.
Yeah, it's been a really amazing transformation, both within the past 18 months, but also the past, 25 years, at least from when I've been working in this space. I think, right now there's been a lot of interest in really thinking about, sort of racist practices within specific institutions like, hospitals and so forth. And I think there's also sort of this emerging body of research that's really about place-based kind of proxies, in addition to segregation, but like these disparity indices at the neighborhood level and so forth. And I think those are all really useful. And I think, back to your point about like, where should the scholarship be going? I think we really need to uplift what Rukai was saying about intersectionality at the structural level. A lot of times we think about intersectionality at the individual level, but we also need to think about structural intersectional oppression across multiple institutions. And I think that's definitely going to be an emerging space. There's a handful, maybe like 3 or so articles, maybe a half dozen that I'm aware of. But that's certainly an important space. And then finally, again, not only should we look at sort of racism within specific institutions, but again, across institutions, the flow of money, the flow of information, the flow of informal and formal practices. Those, I think, are probably the most difficult things to think about, to measure, and to encapsulate. But I think that's really where, if I were to say like, hey, 10 years from now, where do we really need to make some progress? I think that's where we need to go.
These are great thoughts. Sandra, I want to also lean into the positive. So I'm going to try to take something that is negative and find out how to lean into the positive. Joe, I really appreciated that the last phase you mentioned is the backlash. It is easy to be naive about the degree of backlash, particularly in certain circles where people are mostly surrounded by people of similar ways of thinking and maybe not be aware of it. A number of people in the audience have sent in questions related to misinformation, related to the undermining of democratic institutions, the undermining of science, and the ability of people to promote theories and arguments that are not evidence-based. So to the positive, my question is, what can those who are working in this field do with awareness of backlash to solidify gains, protect against the backward slippage? Another question that came in, Gilbert, to you was, how do we hold the coroner accountable? You tell the story of that. So I don't want to turn this into a poli-sci one question conversation, but from a health systems and health research perspective and a public health perspective, what do we do now to avoid or reduce the likelihood of slippage as that pushback potentially gains momentum?
Well, I can take that from the top since you addressed the positive comment I made. I have in my writing suggested that there are two things that we as an academic community, given sort of the nature of this panel, do. One is that we make a scientific argument, and one is that we make a moral argument. The two are different. Neither of them are sufficient, and both are necessary. And I think there are different kinds of arguments that we make. And, I use examples to illustrate that you make a scientific argument by itself, you're not really going to change how we think. We're not really going to change action. And similarly, if you make a moral argument without a scientific argument, frankly, we give up our expertise as being scholars that are based on the pillars of things like peer review, et cetera. So I do think we need to make both those arguments. And they are tricky arguments to make, because I think we need to make our scientific arguments with clarity of focus to make sure that we are seen as unbiased and that we are providing data on which one can scaffold, as I mentioned earlier, based on the papers in the issue, race-conscious policymaking. And then I think we need to make moral arguments that are expansive and that include as many people as possible rather than exclude people. And I think on both of these, we in the scholarly community have fallen short in the past, X years. That I think we have allowed our scientific work to be cast in a particular light as having more bias than sometimes we deserve, sometimes we didn't deserve. And I think in making a moral argument, we have not been successful in creating as broad a tent as we should. Now, I don't say that naively. I realize there are many actors working in bad faith against us, and I think that is a real challenge that we have to face. But at the same time, just focusing on ourselves, I think with the clarity of 25 years, as Gil mentioned, of work in this area, building forward, with momentum building forward, I think if we can sharpen the tools and the approaches to which we make a moral argument, as well as scientific argument, we can really move things forward. And just to tie it into special issue, Alan, I thought the special issue really did a nice job of doing that. I think there was clear science in it, but there was clear narrative, there was poetry, there were examples. And I thought that was building towards a moral argument. And as a reader, not involved in setting up the special issue, I thought the special issue is actually working on both these axes. So I would applaud you and Professors G and Yerby for doing just that.
Yeah. I wanted to say a comment about the backlash, because it's real and a lot of people are feeling it. And it's gotten to the place where it's not just like individual faculty are being censored, but schools are being, completely kind of retooled and whatnot. I think we need to think about creating safe spaces for people to move institutions if they're in an outrightly hostile political environment where they can't do the research. And as to build on Sandro's point, we really need the good science. And if there are political forces that are impeding us from doing the good science, that's a big problem. And I think we need to find ways to find positions for scholars who are bold enough to work on this. Because, when people don't like your research or they don't like your politics, the easiest thing they can do is shoot down your methods, right? And then you go nowhere. And especially, I think the most exciting and important research is going to be coming from junior scholars, people who have brand new perspectives, who are not satisfied with the status quo of the research from, the many generations before them, because they realize that body of research at many times helped perpetuate the status quo and so forth. So I think we actually do need to find ways to allow scholars of color, people working in these very difficult political spaces, to find places to build their careers, in particular for the junior scholars. There's so many horror stories, and it's not just about the buzzwords like attacks on CRT and everything like that. People are feeling it quite real, and it means their livelihood. And so we need to help protect them and uplift people who are in these bad places.
And I was just going to say that we need to harness the law, Because the law says that people should not be discriminated against based on race. It also says that these institutions have a responsibility, a legal responsibility, to ensure that everybody is treated equal. And that is not happening. And so to me, not only do we need to make the arguments about moral, financial, but that it is a legal requirement to do this work and to eradicate racial discrimination. And whether that means that you provide support, and equal ability for racial and ethnic minority individuals, or any individual studying structural racism or racism, to continue to do that work, and bringing lawsuits to challenge when they are not able to, but it also means moving and requiring governments to fulfill their responsibility, as the Supreme Court has recently reaffirmed, as healthcare institutions need to do. And so I think we need to work together to use those legal tools that we have to push forward and to make them an option, not only just in our research, but also in the courts and with policymakers, to ensure that we can continue to do this work.
If I could just add one quick dimension here, I think, veterans of this movement for, decades, very clearly told people like me and others, predicted that the ebbs and flows of this work will come, that when we gain ground, there will be this pushback. And so, I think that's something we need to understand. I think that we need to channel our emotional energy less in kind of food fights, and more on being strategic. This time calls for thinking about what are the tools now that we can leverage to advance this work. Clearly this work over the course of our nation's history hasn't always changed hearts and minds, but we have changed laws and policies and practices. And our ability to now capitalize on that, and in the healthcare space, really think about execution, the rigor of that execution that we haven't had, is just another piece that I'd add to this discussion.
Well, Joe, I'm glad you jumped in, because I was actually going to call on you for a slight angle on what you just said. So if I can just keep you for a moment. I mean, you have a paper in the issue that's talking to reporting out what equity officers in health systems are doing and thinking, and you led efforts in a system before you were in your current job. And so I think, first of all, you have the credibility to speak to these things, but I really want to ask you about sort of the ebbs and flows and what it takes to build the institutional support. Because I think, one of the ways both of you have talked about sort of, laws, and all of you in different points have talked about laws and structures. One of the ways to buffer against ebbs and flows is to build institutions that have systems in place that are designed to move forward. It's just how structural racism works also. It builds the racist structures. And so you can build structures in institutions that have positive effects to dismantle. So I wonder if, Joe, if you could just spend a little bit more time sort of talking about your own experience and what it takes to build that kind of infrastructure.
Yeah, it's been a journey, Alan, and I think ultimately it is about knowing your local environment, knowing the currency, really bringing the tools of change management, and building that foundation, securing buy-in. These are tools, quite frankly, that are used in change management in a lot of different ways that we have to really apply to this work. It requires being a good student of everything else that's on healthcare leaders' table to understand how to assure that this becomes front of desk, not side of desk. And I think that's been a long journey. And I've always viewed this as positive progress as progress. It's never been at the scale or speed that I think I would have liked or we would have liked. And I think it also is influenced very much by, the local environment. All politics is local, and we have different environments across our nation, different states that have a different political milieu that make some of this work a lot more challenging, just to be blunt, and others that make it easier. And in those places that's a bit easier, that's where we need to create those models for success that we could then leverage elsewhere. I'd say that, part of my journey has been one where you aim to build, be strategic, and really add that rigor of execution. And I think we need to also be careful of where there's, big efforts, but we look under the hood and that quite frankly, that level of execution isn't there like it was. Because something is big, it does not mean it's better from the standpoint of execution, especially when it requires the type of work that this requires. So just a couple of reflections from my experience.
That's great. Thank you so much. Well, as we're coming to the end of this, I wanted to ask you both what makes you optimistic and what worries you. I've actually heard enough worries to get me through the afternoon. So I'm going to put that part of the question aside and just ask as we finish up, what makes you optimistic? What keeps you going at this because you believe something positive will result? Whoever wants to go first, love to hear your thoughts on this.
I guess I'll jump
Please.
in. This whole space right now that we're having makes me optimistic, right? So, many journals, including Health Affairs, but many other journals are moving into, requiring that authors justify their use of race, for example. And many journals are also having special issues on racism, structural racism, and various things like that. I really applaud the leadership of Health Affairs in this space for sure. And then also lots of funding agencies, NIH, for example, is putting, calls for proposals as well as working within their house, the National Academies of Medicine, for example, and many other important bodies that are really focused on research and practice and everything are having frank conversations about racism. If you go back like maybe 5-10 years, people wouldn't even feel comfortable saying the word racism, because it would be seen as illegitimate, as too political, as too biased. And now people are actually using this very simple word. And so I think, plus all the new people that are coming in to work on this, all the young scholars, I think that makes me very optimistic.
Great. Someone's ready.
I'll jump in and just say what makes me optimistic is that the governments that declared racism as a public health crisis didn't just make a statement. Many of them began the work on repair, and whether that was truth and reconciliation, acknowledging the harm that was done in terms of racism, but also working towards reparations to repair the generational harm for racism. I would say the last thing that I am excited about is the recognition that racism harms all of us in the United States. It saps the strength, as Dr. Kamara Jones has said, saps the strength of the entire society. And so I am excited about the fact that we're beginning to understand how we all are harmed, but disproportionately people of color, and we need to work to repair those harms that are both historical and modern day.
Well, maybe I'll jump in. I suppose everything Dr. G and Dr. Yerby said, Professor Yerby said, but just to hone it down to, in my mind, number one is, the way the world changes is by changing policies and structures, as Professor Yerby has reminded us many times during this past hour, and by also changing hearts and minds. And I think there's tangible evidence of movement on both. I actually think that there are, we're answering this only from the positive. I don't want to forget negatives, but answering from the positive, there are concrete policies, there are concrete laws being passed there, particularly at the local level, which I think is optimistic. That's number one. And I also do think that there has been a cultural shift. There's a shift in how society thinks. I think that's all positive. And I think the ultimate thing that gives me most hope is the next generation. I mean, here we're talking from a scholarship perspective. When I look at the special issue, a lot of the papers are led by, almost all the papers have a representation by early career scholars, which of course means that in 20 years' time, those scholars will have spent their formative years of their career fully embedded in thinking about these issues. And I think that gives enormous hope and optimism.
Joe, last word to you.
Yeah, just doubling down on new generation, unprecedented research and leadership in this space, real acknowledgement of disparities and how racism impacts them, and how they are a key part of quality and value. Real advancements in what we're seeing from CMS and also payers. There's pushback. People need to be strategic and patient. This wave is too big to be blunted. And so, I think that's the posture we need to take. But if I look at the arc over the last 20 years, we have bent that towards, a more just and moral universe. And I think, those vectors come and go. We just need to continue to contribute to those vectors in a positive way.
Well, thank you all. And I'm going to stick with this wave is too big to be blunted. I think that is really what we need here is a wave strong enough to withstand what will be pushback, but also to acknowledge that it will exist. The wave needs to be stronger. So thank you all to our theme advisors. Keep saying thank you. Also, Sandro and Joe, for your contributions today and in other contexts on this critical issue. It's been great having you all. And with that, I'm going to take us to the next part of our program. We do have our poet available and ready to go. And so I am going to next introduce Ryan Pettaway, Associate Professor at Oregon Health Science University School of Public Health, reading a poem published in the issue. If we can get Mr. Pettaway, we'll turn it over next to you.
Yes, thank you. Excited to be here and do this. Do I need to give any background on this piece, or should I just hop right into it?
I loved it straight in, but it's your few minutes.
Okay. Yeah, I would say that I started working on this in late 2021 when the data started coming out, the GIS and mapping data regarding COVID, vulnerability indices, and I started to reflect on the ways in which we kind of tell these stories sometimes, and we leave out a lot of pieces, the historical context, embodied experiences, local knowledges, those sorts of things, right? And so that's kind of where the piece originated around that time frame. I'm excited to have it in this issue, and I'll go ahead and get into it. This is Proc Prune Roses. To live and die in a confidence interval is nothing like LA or any place I've known. Run. Error. 76-332 syntax error statement will be ignored. Have you ever seen Kai Squared use a pen? I haven't quite figured out where exactly I should cut myself to partition effects fixed upon my skin, mixed inside my hood with spoons that say random shit like Proclimics and Cove Test. Run. Error 76-332 syntax error statement will be ignored. I can hear my great-grandmother saying I better not scratch up her good pots with that shit. Only she was religious and pruned rose bushes and would be much more polite, even invite these procking types to prayer. Blessed be thy name, blessed be thy name, blessed be thy sampling frame. Random, digit dialing, calling us all sorts of names we did not inherit, like marginal and vulnerable, painting us rose. Our place of beauty, buried beneath a stranger's choropleth, unnaturally broken death, and pretty decay. Blessed be thy swab, blessed be thy last 30 days. Come, lay your burden at the cross, sectional. Wait. Are they proc pruning us? Run. Error 76-332, syntax error, statement will be ignored. Blessed be thy hands, thy methods keen to fracture, bone and flesh and street and story, turn them into factors. Blessed be thy tongue, thy unprincipled components. Tell me, which component of no don't you understand? Run. Error 76-332, syntax error, statement will be ignored. Blessed be the flower, the whole flower, the full garden. We full bloom, we pretty, we rooted, we longitudinal. Promise, put that on my grandmother, on God, my word, my home, my homies versus your G's, and see who comes out marginal. Run. Error 76-332, syntax error, statement will be ignored. I recall Nas and AZ, and I'm reminded probabilities a bitch and then you die, or at least that's how I think it works. Run. Error 76-332, syntax error, statement will be ignored. Have you ever seen an epidemiologist at a ballot box, blacking out ovals, humming Tupac. I haven't yet. Quit. That's all. Thank you.
Thank you so much for sharing that with us. We're so pleased to be able to include it in this issue and have you as part of the program today. I'm now going to turn it over to Dr. Vabren Watts, who will moderate the next panel of the program. Over to you.
Thank you so much, Alan, and thank you, Mr. Petaway, for that poem. Good afternoon. As Alan said, I'm Vabren Watts. I am the Director of Health Equity for Health Affairs, and I will just say that as a health equity officer, it is amazing to work for an organization and be connected with sponsors which are interested in continuing this conversation around racism in health. I have the honor to start off our first panel of authors featured in this month theme issue. The topic of this panel is Politics and the Legacy of Racism. You will hear from, in this order, Jason Saprini, postdoctoral scholar at the University of Iowa, Chanel Diaz, assistant professor of medicine at Columbia University Irving Medical Center, Jamila Mishner, senior associate dean for public engagement at Cornell University Brooks School of Public Policy, as well as Jacqueline Yan, assistant professor at Dornsife School of Public Health at Drexel University. We will have a question and answer session after all presenters have presented. We will first start out with Dr. Saprini.
Thank you very much. My heart's bumping a little bit after that poem, so bear with me as I kind of settle in here. Thank you very much. My name is Jason Saprini. I'm a postdoc at the University of Iowa College of Public Health, and I'm pleased to present our research where we found that Medicaid expansion lowered uninsurance rates among non-elderly adults in the most heavily redlined areas. Before highlighting this study, I'd like to first thank my co-authors. First, Abi Nasir Ali. He is not just a skilled researcher, but his knowledge on housing and policy and the interplay between housing and health were fundamental to this work. Abdi is actually on the job market this year, so if your institution is looking for a skilled researcher and housing economist, look no further. Second, I'd like to thank Dr. Gabriel Benavides, now Professor Benavides. Gabe's an excellent epidemiologist, and his knowledge on the geography of health equity helped to make this work possible. For supporting our growth, my growth, studying health equity, I'd like to acknowledge my mentors, Dr. Funmi Olopade, Dr. George Webby, Dr. Whitney Zond, and Dr. Mary Charlton. And lastly, I just want to thank Health Affairs for allowing us to promote this paper and put us on this platform. Personally, I never thought I'd get to present alongside so many experts, specifically Dr. Michener, whose scholarship on Medicaid was in part motivating this study. And Dr. Michener, it's my humble opinion that you're among the most important scholar kind of driving the direction of Medicaid policy research today. So thank you. But let's get to our study here. So I'm sure many of you are familiar with the Affordable Care Act's Medicaid expansion, which lowered uninsurance rates and narrowed racial ethnic health insurance coverage gaps. However, while we've seen a lot of research showing differential changes by race, we have yet to see attention on the role of racism. In our study, we looked at one specific form of structural racism, residential segregation by redlining. And there's been tremendous work showing the legacy and negative consequences of this racist practice. But our contribution is aimed to assess how a policy differentially impacted communities based on their exposure to this redlining. Next slide, please. So before the Affordable Care Act's Medicaid expansion, you'll see that uninsurance rates were highest in the communities that had the highest level of redlining. That'll be the blue bars here. It's about a 20 to 30% gap between these communities, between the lowest and the highest level of redlining. Next slide, please. And what we found in our work is that the ACA's Medicaid expansion had the greatest drop in uninsurance was found in these heavily redlined communities. Relative to the drop in non-expansion states, we attribute Medicaid expansion to have reduced uninsurance rates in these heavily redlined communities by about 6 percentage points. And this reflects a 20% decline from baseline. And in no other census tract redline categories do we find any significant change because of Medicaid expansion. Next slide, please. And so while Medicaid expansion's effect varied across redline categories, again, with the strongest effects and the only significant effects in the highest redline category, there was little difference that we found between racial ethnic groups, specifically people who were non-Hispanic Black, reporting non-Hispanic White, or reporting as Hispanic in the census data. Very little differences across racial ethnic groups. Now, there's a lot to unpack here, and we look forward to discussing it further on this panel or ongoing. But in brief, the legacy of redlining was systematic disinvestment, and not just for families, generational wealth, but entire communities. Looking at this together, we believe our work suggests that the ACA helped respond to the negative consequences of structural racism by providing affordable health insurance to millions of low-income Americans who are disproportionately living in these redlined communities. And states that continue to delay expanding Medicaid are also delaying the pursuit of health equity, as the largest number of the expected beneficiaries are residing in these previously redlined communities. Next slide, please. Racism, not race, is the cause of racial ethnic disparities. So we as investigators and scholars must do a better job to incorporate this into our policy implementation and evaluation work. This map here shows the redlining categories of my state's capital, Des Moines, Iowa, and life expectancy. There's a clear pattern. There are many of these patterns that have been shown in the field. It's one thing for a policy like the ACA's Medicaid expansion to lower uninsurance rates in specific communities as a response to structural racism, but that isn't enough to actually improve the lives and livelihoods. We hope our research helps motivate continued attention to the role of structural racism in health and how policies can respond to its negative consequences. But most importantly, we hope our work motivates the continued expansion of innovation and investment needed to overcome the impacts of and alleviate entirely structural racism. Thank you.
Now we will hear from Dr. Chanel Diaz.
Thank you so much. I'm Dr. Chanel Diaz, and I'm thrilled to have the opportunity to share a little bit about our commentary, Advancing Research to Address the Health Impacts of Structural Racism in U.S. Immigration Prisons, which I co-authored with Drs. Joseph Nwadigo, Altaf Sadi, and Caitlin Patler, who are incredible researchers and advocates in this field. In this commentary, we provide a framework for understanding the multi-level health consequences of mass immigration imprisonment, and importantly, to contextualize it as a structurally racist driver of health inequities. Next slide, please. The United States is a world leader in imprisoning immigrants, and even though immigration law is civil law, on any given day, over 30,000 immigrants are imprisoned in punitive conditions while awaiting a determination in their removal proceeding. Many imprisoned immigrants are held for years with limited access to attorneys or other constitutional protections available under U.S. criminal law. This mass immigration detention system emerged as an extension of mass incarceration, both rooted in a legacy of racist U.S. immigration and criminal laws. Going back to the Naturalization Act of 1790, which limited U.S. citizenship to white people, to laws in the 1800s that excluded Black immigrants from citizenship, and the Chinese Exclusion Act of 1882, U.S. immigration policy has been used to define racial groups based on their proximity to white men. Next slide, please. Immigration policy is a critical but often overlooked structural determinant of health that negatively affects the health of imprisoned immigrants, their families, and their communities. At the individual level, a robust body of research has made it clear that immigration imprisonment is harmful, even deadly. And while imprisoned, immigrants are subject to the neglect of basic needs such as nutrition, are placed in physical environments that accelerate illness through overcrowding, poor sanitation, and exposure to physical violence and sexual assault, all in the setting of grossly inadequate healthcare. At the household level, families bear the collateral costs of imprisonment, which removes millions of dollars from local communities and lost wages, as they're forced into a state of heightened threat, uncertainty, and psychological distress. Growing evidence also demonstrates that immigration prisons and the immigration practices that fill them are associated with population-level reductions in healthcare and benefits utilization, delays in prenatal care, increases in childhood poverty, and overall poor health outcomes. Next slide. Next slide, please. Okay, thanks. The systemic harms of immigration prisons have been extensively documented. And I want to be clear that we're not just talking about a few problematic immigrant prisons. We're really talking about a system that's flawed. And thus far, incrementalist reforms have failed to result in improved outcomes for immigrants and may have unintentionally reinforced the structurally racist system. We argue in the commentary that ending the practice of immigrant imprisonment is the most effective solution to mitigating its harms. We know that community-based programs are safer and less expensive than imprisonment, and equally effective at ensuring compliance with government requirements. Next slide, please. We identified several priorities for health and health policy research that can begin to tackle the health inequities resulting from immigration imprisonment. And these include applying a critical intersectional lens to studying the policies and practices that actually drive imprisonment. Secondly, engaging affected communities in research and policy development. Thirdly, dismantling assumptions embedded in research funding and policy about whose health deserves attention. Studying the societal benefits of ending the practice of immigration imprisonment from a strengths and assets-based approach that really humanizes people in immigration prisons and highlights the contributions of immigrant social movements. And finally, creating an accountable and transparent system of data collection and release to inform health interventions. I want to close by emphasizing that our current immigration enforcement laws and policies reflect how the lives of immigrants, and particularly immigrants of color, are valued less than the lives of others. People navigating their immigration case should be able to do so with their families and in community, not behind bars. Dismantling this harmful system is imperative to addressing health inequities in immigrant health. Thank you.
Thank you. Next, we have Dr. Janila Mishner.
All right. Hi, everyone. I am happy to be here today and happy in particular to be on this panel, which is an opportunity to stand alongside or sit, as it were, in our Zoom room alongside so many excellent papers and presentations. And I think the overarching goal here, which is to push us forward, to help us to advance in our thinking around structural racism and health equity, is really reflected in each paper. So I'm happy to be a part of that. So let's jump right in. Next slide, please. I really start off the work that this is based on, focused on racism, power, and health equity, around a claim that political power is a fundamental determinant of health equity. And it's a claim that's substantiated. It's not something that I'm the first person to have said, but it's certainly something that we can overlook. Often when we're thinking about health equity, we're thinking in terms of particular health outcomes and disparities in those outcomes. And we often link disparities in those outcomes to what we might think of as demographic or group-based factors, right? And so it may be race as a demographic category linked to a variety of disparities in health outcomes. And we are interested in chronicling those disparities. We're perhaps interested in understanding them, how they might differ in different places, what their determinants are, whether their determinants are rooted in housing or other kinds of systems and domains. But ultimately, what we want to do is not chronicle the disparities alone, but we want to change them. We want to alter them. And what does that mean? So knowledge and the production of knowledge is a part of that, right? By knowing more about the nature of disparities or the nature of negative health outcomes, who they affect, patterns in who they affect, we can get more traction on what sorts of changes are needed. But knowledge in and of itself is not enough. To get from knowledge to action, to get from having identified a problem to having understood that it's a problem to change, we need to go through some processes. Those are political processes. They're policy processes. They're ultimately the pathway to changing the systems that we're all identifying problems in here today. And that requires political power. It can be a little touchy to talk about. We're in a context, I think, especially today, where politics is messy and it's divisive and it's polarizing, and we can want to avoid it. But at the end of the day, we cannot achieve health equity and we can't advance it without attending to power. So next slide, please. What do I mean when I say power? I mean the capacity to influence social and structural conditions, the conditions that affect your life and your community and your world. And often when we think about power, we sometimes tacitly, sometimes explicitly think about it in terms of elites, people who are policymakers, people who have status, who have position, who we think are the ones calling the shots, making the big decisions. But in this research, I really think about power from what we might call the bottom up. Next slide, please. And I do that through the lens of housing. Next slide. I do that through the lens of housing. And really, I use housing and specifically under the umbrella of housing, tenant organizing as a way of a kind of case that helps us to see how power and structural racism and health equity are connected to one another. Those are all big, sometimes abstract concepts that can be hard to grasp in the concrete. And using housing, which we all think of as an important determinant of health, as a specific case to help us gain traction on that, is a way of making real the kind of otherwise abstract conversation that we might have about power. Next slide, please. And in particular, power is important to think about in the context of structural racism, this is one way we might define that, because often these systems, the social, political, and economic and ideological systems through which structural racism operates, the lifeblood of these systems is power, right? Who has the ability to influence these systems and to continue to support the operation of these systems towards ends that continue and perpetuate structural racism. So next slide, please. In particular, I think about structural racism in the context of housing and through the lens of housing. And here's just an example of a bunch of reasons why structural racism is particularly relevant to housing, right? And we know, we've seen research, many of us have seen research on these various processes, right? Whether it's discriminatory lending processes or white flight or what have you. There are many policy and process-oriented mechanisms through which racism has come to matter in the realm of housing. Next slide, please. But I really want us to think about what this means for specific people. I open up the paper with the story of a woman named Sheila, who talks about how she has very few options in housing. She's had all sorts of terrible things happen to her in her housing, from a home fire to mold to her home causing illness in her children. But she's in this situation that's described here on this slide, where she's dealing with a very ill child and has very little options for going elsewhere. And so she's stuck, right? Next slide, please. And her landlord ostensibly knows she's stuck. And she talks about herself through the lens of being a tenant. And she says, tenants like me don't have any power, right? And ultimately says, people who look like me, people who are in the same income bracket. And so it's important to understand that the health undermining housing scenarios that someone like Sheila is facing remain that way in part because Sheila doesn't understand herself to have and doesn't have the power to change the circumstances that she's facing. Next slide, please. But income organizing, right? Sheila by herself perhaps has limited power and influence. But through organizing, and by organizing, I mean not just that Sheila can identify systemic problems, but that she can work together collectively with other people like her to attempt to change them. Through those sorts of processes, someone like Sheila has much more of an opportunity to create change. Next slide, please. So how does this happen? This is really what the focus of the paper is, and I'm going to cover this really quickly in just a few more seconds. But next slide, please. I use qualitative data described here and described in the paper. I interview 79 people to understand what tenant organizing actually looks like and what possibilities it holds for addressing and improving and advancing health equity in the face of structural racism. Next slide, please. And really, I use examples from people who talk about the logic of the relationships between organizing and racism, people who are organizing collectively because they understand the way that racism has worked in the housing system. They talk about the historical way that housing has been used to racialize generations. They talk about the systemic use of housing. They talk about keeping Black neighborhoods destabilized, or how you treat Black women, for example. Next slide. And these folks understanding this come together and they have mechanisms through which they can resist racism. And tenant organizations do this in a number of ways. And I point these ways out in the paper. One is through direct action, right? There's a specific problem and tenants can organize to address those specific problems, the mold in the building, the lack of water, the conditions that are undermining their health, right? And then through policy campaigns. That's broader than just specific particularistic problems. It's about big picture things, changes in the way systems are structured and operating to affect people negatively. Again, I give these examples on the slide and in the paper of how people very concretely organize together through tenant organizations to build power and then exercise that power to change on both a particularistic and a broad level the health undermining circumstances that they're facing. Next slide, please. And the paper is really, and the research is really geared towards pointing to specific ways that racially and economically marginalized tenants, in this case, but populations more broadly, can build power to actually change the conditions that are undermining their health. And final slide, please. I'll end here by saying one large implication of this is really a shift in how we think about the pathway to changing health equity, an incorporation of the people who are bearing the most of the brunt of structural racism and health inequity into our lenses, into how we think about the political processes through which health equity will be changed. It will be changed by and with the people who are most affected by it, and understanding the processes through which they do this is a critical next step to growing our knowledge of and changing the systems that perpetuate structural racism. All right, I'll end there. Thank you.
Thank you so much to all of our panelists. Now is the time for questions, and our panelists will answer those questions. But before everyone, we'll ask everyone type in their answer. Oh, I'm sorry. We have one more guest, and we have Dr. Jacqueline Yan. Sorry about that, Dr. Yan. The floor is yours.
That's okay. I can make this quick. So we have plenty of time for Q&A.
Please take your time.
Okay. So thank you. I'll be presenting today some work that I did alongside a fantastic team of co-authors that I'd like to take a moment to acknowledge now. They are myself, Dougie Zubizarreta, Jarvis Chen, Belinda Needham, Colleen Samari, Alicia McGregor, Megan Douglas, Bryn Austin, and Medina Ajnor. This was an incredibly collective process, and I couldn't have done this paper without them. Next slide, please. So we know, and some of the discussion today has highlighted just how important state laws are for perpetuating structural racism under federalism, and Dr. Michener's work has shown this especially. States are so important for, state laws are incredibly important for encoding structural racism and enacting racially inequitable implications. We can also think historically about the ways that our current policy follows a legacy of structural racism in state laws, including Jim Crow laws, which were a legal regime that was aimed at maintaining white supremacy through disenfranchisement, segregation of services, resources, and accommodations after the abolition of slavery. And then also we can think about the ways that Jim Crow laws were not just one law that had these broad effects, but many, and the ways that many laws worked together to completely legalize racial discrimination. And so today, often in our health policy research, we focus on single laws, but we might, with that narrow focus, be missing the combined effects of multiple laws, particularly with respect to structural racism, because of the ways that structural racism interacts across multiple domains and areas of social life. Next slide, please. So the objective of this paper was to develop a measure that describes the co-occurrence and social patterning of state laws that legislate racial inequity across US states. And then we wanted to examine associations between those groups of state laws related to structural racism and premature mortality. Next slide. So to do so, we used a database put together by, led by Medina Ajnor and a group of public health and legal scholars who drew upon critical race theory and existing scholarship to identify a set of state laws that both perpetuate structural racism, which we call here harmful laws, or are actively attempting to mitigate racially inequitable implications, which we call here protective laws in the teal. And then we used latent class analysis to look at where those laws co-occurred across states in the US. What we found was broadly 3 groups of states. The first was a group which had largely harmful laws. So we see mostly orange in the top group there. The second was a group of states with largely protective laws related to structural racism, or more inclusive laws. And the third was a group of states with a mix of both harmful and protective laws. So for example, this group of states had particularly harmful laws related to immigration protections, but protective laws related to housing and providing people eviction, notice before eviction. And so our next step in this work, thank you. My slide change. Our next step in this work was to look at the ways that these groups of laws are geographically patterned. What we see in the red are the group of states with mostly harmful laws related to structural racism, with strong patterns in the US South. In the teal, a group of laws related to structural racism, mostly on the coast, but also spread across the middle of the country. And then the third group with mixed protective and harmful laws, kind of no clear pattern, although a couple in the Northeast. Then, strikingly, we looked at the overlap between states within each of these classes and historical Jim Crow laws. And what we found, shown in those white stripes across the states, are that 18 out of 29, or 60% of the states in Class 1 historically had Jim Crow laws, potentially indicating the ways that these groups of policies and not just the policies, but also the political context behind them have deep legacies historically and continue to live on and shape our current policy. Next slide, please. And then lastly, what we wanted to look at was really the relationship between these groups of state classes and premature mortality rates. What we observed was a clear pattern whereby premature mortality rates were highest in the groups of states with largely harmful laws as compared to lower rates in the teal in states with mostly protective laws, and something kind of in between for that third class. We observed a similar pattern across racialized groups among Black and white adults, although with some wide confidence intervals among Black adults. Next slide, please. And what we hope folks take away from this paper is that we want policymakers and researchers to consider not only single laws alone, but the ways that structurally racist policy clusters and forms policy regimes. In addition to the importance of individual laws on health and population health inequities, we need to be thinking about the ways that groups of laws collectively act together and reinforce each other's strength. Next slide, please. Thank you.
All right. Thank you so much, Dr. Yan, and thank you so much to our other panelists. The chat is open for questions, so please put in your questions. But as you put in your questions, I'm going to start asking some questions, and I'm going to start first with Dr. Semprini. Dr. Semprini, you mentioned that innovations are needed to further lower uninsurance of redline communities, particularly among those groups who have been historically discriminated against. What innovations will that, I guess, what could those innovations look like?
Yeah, thanks, Dr. Watts. I was speaking more to the needing to extend beyond just thinking about health insurance coverage. That's a critical component to access, and the Affordable Care Act did a great job addressing that concern. But if we want to actually improve people's lives, we want to lower mortality rates and not just narrow coverage gaps, but narrow life expectancy gaps. The innovations there, whether it's health sector, whether it's innovations to create networks to improve the quality of care delivered in some of these previously redlined communities, or if we're looking at outside the healthcare sector work, whether it's related to housing, whether it's related to education. So just really expanding what we think about when we want to drive health equity. It's got to move beyond insurance in this coming decade. Thank you.
Thank you. Dr. Diaz, one question that I have for you. You spoke about moving towards abolitionist policy solutions to mitigate the harms of immigration prisons. Can you talk more about that?
Sure. Thank you so much for that question. So in terms of moving towards abolitionist solutions, what we're proposing is really dismantling the structures that are in place that are driving immigrant imprisonment. And so that means looking at our immigration enforcement policies. It means looking at policies that are parts of our appropriation bills, like the detention bed quota that requires a minimum of 34,000 beds funded at any given time for the Department of Homeland Security. And so it requires also looking at our criminal justice policies and the ways in which Black and Brown communities are policed and disproportionately imprisoned, because really that provides a pipeline into immigration prisons as well. And so I think that there's a lot of overlap when we think about these structures. It requires looking at incarceration overall and decarceration efforts, and really bridging those with efforts around ending immigration prisons.
Thank you. Dr. Michener, someone has a question for you that actually speaks to religion. They want to know, why isn't religion in the list of systems that work to ensure racism? A lot of us have come to realize how religion is rooted in racist ideology in the US and therefore support power structures and enforcing racism.
Well, that's an interesting question. I mean, I can only speak to why I don't mention religion, which is very simple, which is that I don't study it, right? And certainly there are a lot of, when you look at the definition that I offered in terms of structural racism, part of what's in there is that it's ideological systems and processes that are upholding structural racism, in addition to political and social and economic systems. And all of these things are interconnected. And religion can be a part of that. Now, of course, religion is a huge umbrella. It's a huge category, right? And so, like, what are we talking about when we say religion? What sorts of religious institutions? Different religious institutions play different roles. So, for example, in the civil rights movement, churches were religious institutions that played a large role in, like, advancing racial equity. And I talked about tenant organizing in the paper, and there are lots of faith-based organizing efforts that go on, right? So religion is a very broad category, and it doesn't only cut one way. There are religious institutions that have sometimes worked on behalf of efforts around racial justice, and other times have not. And there are religious ideologies, for example, that can reinforce and perpetuate structural racism. And there are other kinds of ideologies that are faith-based that don't do that. So I think there's a lot to break down there, but it's certainly something important to consider.
Thank you. Dr. Young, we have a question for you. What were examples of harmful and protective laws used in your analyses?
So great question. Thank you. So there were kind of a couple broad groups of legal domains. Many laws include ways that structural racism is perpetuating inequities across socioeconomic strata and creating unequal, disproportionate, both in terms of income inequality, but also in terms of access to economic opportunity. So, for example, some of our laws included minimum wage laws, laws related to the earned income tax credit participation across states. We also had a couple criminal legal system related laws, for example, related to a penalty for not showing ID when a police stops a person. Also laws related to education and corporal punishment in schools, and immigration protections, including inclusion in in-state tuition, and a variety of laws. So please do read the paper for more, and please read Dr. Agenor's original paper, which includes much more detail about the different laws and legal areas.
Thank you. Dr. Saprini, a guest of ours could you clarify your definition of redlining?
Yeah, thank you. We used the definition and the data from the Mapping Inequality Project, where they categorized community blocks, I believe, based on a residential score to determine access to homeowner residential loans. This is practiced in the 1930s. And a low score was, I believe, a definition was related to high class of white citizens with different groupings, all the way up to the highest, which was specifically targeting towards to people of color, specifically Black Americans.
Thank you. Dr. Diaz, we have a question from an attendee which asks, have mental health statistics been reviewed in effort to dismantle these destructive, dehumanizing immigration imprisonments that lead to lifelong trauma disorders such as PTSD, anxiety, etc.?
Yeah, so part of the body of evidence that we cover in the article includes evidence around the mental health impacts, around the trauma experienced while in detention. But one thing that I do want to highlight is a really important study post-detention that really highlights the resilience and the mental health benefits of release. And that was led by two of my co-authors, Dr. Caitlin Tatler and Dr. Altaf Sadi, and they actually found improvements in mental health outcomes following release. And so while we know that these systems are incredibly harmful, we also know that that there is a solution to address some of these harms, which is getting people out. Really important, and really providing necessary mental health services post-release.
And this is a question that any one of the panelists can answer. It is, what are strategies that you all have found helpful when conversing with individuals that or groups that deny the existence of structural racism? How do we respectfully respond to the backlash without fueling more defensiveness?
I will quickly jump in here. I mean, I guess I would say the first thing I always try to determine is whether whoever my interlocutor is somebody who is open to learning and engaging in good faith. I think there are folks who, for a variety of reasons, do not want structural racism to be a factor in how we understand social, economic, and political life. And if folks, for personal reasons, for ideological reasons, are unmovable on that score, it's not always worth expending the energy if folks aren't engaging in good faith. Now, if someone is engaging in good faith, then that means that you can bring evidence to bear, and we have a lot of it. And it also means that you can bring the experiences and perspectives of people who have experienced structural racism to bear, which is part of our evidence, but often is a kind of narrative evidence that people can find compelling. And so I think, our comparative advantage as scholars is that we have and understand and have access to a wealth of research and other kinds of evidence that people don't always know about. And I think we can play our role in exposing them to it. And then the rest is up to folks, to whether they really want to listen and whether they're open to learning.
Yeah. Well, our session is up, and I would like to thank all of our panelists for this conversation about politics and the legacy of racism. We all learned a lot, and I look forward to actually continuing this conversation offline with each of you, because I really learned a lot through that. As we move on in the program, I would like to introduce our next moderator, who is Dr. Andrew Anderson, who is a assistant professor at Bloomberg School of Public Health at Johns Hopkins University and a former health equity fellow for health affairs. So I turn it over to you, Andrew.
Thanks for the introduction. So I have the pleasure of introducing the next panel, which is entitled The Use of Race and Ethnicity Data. We have three panelists. The first panelist is Michael Paul Carey, who is the Elizabeth C. Clipp Term Chair of the Duke University School of Nursing. Our second is Tina Hernandez Broussard, who's the Associate Dean of Research and Professor of Medicine at Stanford University. And our third, Dennis Angiel, who's a statistician at RAND. I'll turn it over to Michael Carey. Oh, actually, yes, there we go.
Thank you, Andrew. Greetings, everyone. My name is Michael Carey, and on behalf of my dream team and co-authors, I'm delighted to share with you a little bit about our work in mitigating racial and ethnic bias and advancing health equity in clinical algorithms. All right. Next slide, please. So just as a bit of a backdrop, in August 2022, the Department of Health and Human Services issued a notice of proposed rulemaking that would revise a section of the Patient Protection and Affordable Care Act. And in this notice was a new provision stating that covered entities, which are defined as healthcare systems and providers, must not discriminate against any individual through the use of clinical algorithms in decision making. And however, the proposed rule did not specify what measures health systems and providers should take to ensure this. Instead, it solicited comments on best practices and strategies to ensure that algorithms are not discriminatory. Next slide, please. Continue to the next one. Great. So anticipating that many health systems and providers would begin to assess whether their clinical algorithms comply with the proposed rule, and more importantly, attempt to correct any potential biases they uncover, my team and I saw this as an opportunity to identify strategies used to mitigate bias in clinical algorithms. And so we conducted the largest, most comprehensive scoping review to date that helps to summarize a full suite of mitigation approaches that can be applied and used to prevent discrimination arising from the use of algorithms in clinical decision-making. A scoping review included 109 articles comprising of frameworks, reviews, perspective pieces, and scientifically tested healthcare applications and tools. Next slide, please. And on the basis of our findings, we offer the following 7 concrete recommendations for bias mitigation in clinical algorithms. Number 1 is to establish governance structures. So policymakers should encourage health systems to establish governance structures and evaluation plans to prevent potential harms arising from algorithmic bias. Number 2, ensure professional diversity. Developers who build algorithms and healthcare organizations that deploy and monitor them should cultivate and sustain professionally diverse and appropriately trained workforces that comprise of different areas of expertise, from clinical and social sciences to more technical fields. Number 3, require auditable clinical algorithms. Developers and end users of algorithms must provide a clear and accurate information about the intended use and risk of clinical algorithms. Number 4 is foster transparency within organizations. Developers, healthcare organizations, and journals should openly disclose limitations as part of communicating algorithmic outputs, acknowledging biases, and reporting the results of mitigation strategies. Number 5, implement health equity by design. Developers should incorporate principles of health equity by design and mitigate discriminatory effects across all stages of the algorithmic lifecycle. Number 6, accelerate research. Funding agencies and healthcare organizations should increase research efforts focused on bias mitigation methodologies to expand the empirical evidence base for informing choices regarding which strategies to use in a given scenario. And lastly, amplify patient voices. Developers should and must engage diverse patients and local communities in the design of clinical algorithms to inform patient-centered and culturally affirming care. And in the context of the proposed rule, we believe these recommendations provide a path forward for developers, end users, researchers, health systems, as well as policymakers. Next slide, please. In closing, I'd like to invite you to join Duke in our commitment to advancing health equity and promoting responsible AI. We're very excited to announce the upcoming 2024 Research Symposium scheduled for March 13th and 14th at Duke University School of Nursing in Durham, North Carolina. So I want you to stay tuned. There's a QR code here, and stay tuned to further details and registration coming this very week. Next slide. And so a very big thank you to Health Affairs for this amazing opportunity and platform to share a little bit about our efforts and the importance of mitigating racial and ethnic bias in clinical algorithms. And I'll stop there. Thank you.
Thank you, Dr. Carey. We'll now have Dr. Hernandez-Boussard.
Good morning or good afternoon, depending on where you are. So thank you for this opportunity to present our work. My name is Tina Hernandez-Boussard, and I'm an Associate Dean of Research and Professor of Medicine at Stanford University. Today, I would like to discuss our piece that came out entitled Promoting Equity in Clinical Decision-Making, Dismantling Race-Based Medicine. And I'm presenting this work, of course, on behalf of my fabulous co-authors. And so I am excited to be here today. Next slide, please. So we've heard about how important AI in healthcare is. There is a lot of advances in data-driven medicine, and some of these algorithms, particularly in image processing, actually perform as well as, if not superior, than some clinical experts. And we also know that these algorithms require very high-quality representative data to accurately predict the desired outcomes. And these data include social determinants of health. And often we know that these social determinants of health are not routinely captured in the data we use for these clinical algorithms. And therefore, oftentimes, race is used as a proxy for many social determinants of health. And so the problem is that race is actually a social construct. So race and ethnicity can be used in algorithms as a marker of biological differences, but this assumes that people of different racial and ethnic backgrounds have different biological characteristics. However, we know from past evidence that there's greater variation within a race than between races. Therefore, we have an emerging issue about algorithmic bias in healthcare. So there is growing concerns and evidence to support these concerns that a lot of these AI tools actually perpetuate racial biases and lead to health disparities. And biases in algorithms really can result in systematic errors, leading to disparities in treatment decisions, access to care, differences in health outcomes for marginalized populations, particularly for racial and ethnic minorities. Next slide, please. So So there's been many approaches to how we address algorithmic bias, and a lot of these are stemming from policy changes in medical specialty societies. So really examining clinical algorithms that use race in their clinical decision support tools, and how we can look at those. But there's also a lot of advances in algorithmic development, including examination of data biases and representation, the really expansion of methodological approaches to assess fairness analyses. And there's also been a big push in transparency. So really requesting and promoting to have transparency in the data that's been used to train the algorithms, the models used to developing the algorithms, including decisions made during algorithmic development, hyperparameter tuning, et cetera, as well as transparency in source code so that people can actually reproduce the algorithms that are out in care. Next slide, please. And so, so this has really led to what we refer to as race-based medicine. So what is race-based medicine? Race-based medicine is when an individual's race influences decisions about diagnoses and treatments made by clinicians. And because, as I mentioned, race is a social construct, this really reinforces stereotypes, and that has led to treatment differences that are inappropriate, unjust, or harmful. Next slide, please. So here are two examples of where race has been used in clinical decision-making and has really caused harm. The first is with kidney disease and EGRF. So EGRF is used to diagnose and monitor kidney disease, and in the past, this has been adjusted for race. And this is because it was assumed that Black patients had inherently higher creatinine levels. This resulted in underdiagnoses and undertreatment of kidney disease among Black populations. They were actually diagnosed at later stages, and it reduced the chances of them being placed on kidney transplant wait lists. So in 2021, race was actually removed from EGFR calculations. And in addition, the kidney allocation system was revised to address inequalities in allocating kidney donors, factoring in dialysis time. And this was because Black and Hispanic patients historically spent more time on dialysis before transplantation than non-Hispanic whites. And so the result of this was that waitlist times decreased for all ethnic and racial groups, but importantly, the disparity between Black and white patients was significantly reduced. In another example, vaginal births after C-section, known as VBAC, the VBAC calculator estimates risks of a vaginal birth after a C-section, and it was also adjusted for race. And this was because it was assumed that Black patients were at higher risk of adverse outcomes following a cesarean birth. Well, so what this did was this overestimated the risk for these adverse outcomes among Black patients, and therefore it led to differential recommendations and treatment options for these patients. And so it was found that actually race was a proxy for chronic hypertension. The calculator was revised to remove race and include chronic hypertension, and this led to a more equitable estimate of risks across all populations. Next slide, please. So we propose in our paper that we really move to a race-aware approach. So we call a race-aware approach to clinical algorithms acknowledges that there are complex factors involved in these algorithms. And we also know that professionals need to address these algorithms and address structural racism that may be due to factors other than race, such as social economic status, health literacy, et cetera. And so next slide, please. And so we suggest that there are 4 steps to addressing this. The first is to increase trial diversity, so we really understand what race is a proxy for in a lot of these differential outcomes. The second is move from precision medicine to precision care, which actually accounts for social determinants of health in treatment decisions. The third is expanding education and awareness to tackle inaccurate assumptions about race and health outcomes. And finally, to develop guidelines and policies that really are culturally responsive and request and address the issues of capturing social determinants of health. Last slide, please. So thank you very much, and I will stop here.
Thank you, Dr. Hernandez-Broussard. We will move to our next panelist, Dr. Agnew.
Thanks, Andrew. Hi, everyone. I'm Dennis Aniel, a senior statistician at the RAND Corporation, and I'd like to start by thanking Health Affairs for organizing this issue and this event and the invitation to share this work. I'd also like to take a second to thank my collaborators on this project, Araneo Cabrero, Cheryl Damberg, Mark Elliott, and Rihanna Rogers, as well as acknowledge that this was internally funded work supported by unrestricted gifts from RAND supporters and income from operations. So I'll describe in this talk the main ideas from our paper in this issue of Health Affairs, where we propose a new way of measuring quality of healthcare to promote health equity. Next slide, please. So as most people who read Health Affairs probably know, quality measurement is an important tool for incentivizing improvement in the quality of healthcare. For example, Medicare currently reports clinical quality and patient experience scores for many healthcare providers, many different types of healthcare providers. And rewards, either in terms of higher prestige because they're rated highly on these tools, or actual incentive dollars, are typically allocated to high-performing providers. However, most quality measurement efforts don't target health equity because they measure the average quality of care among all patients. This approach will tend to give more weight to patients in larger groups and lower weight to patients in smaller, traditionally disadvantaged groups like non-white or rural patients. And it's a truism in quality measurement that what gets measured gets improved. And so the intention of health equity measurement is to refocus the measurement of quality onto smaller and traditionally disadvantaged patient groups. But it's incumbent on the health equity and quality measurement communities to ask whether we are using the right quality measurement tools to encourage improvement in care for the disadvantaged groups as intended. There are two standard approaches to measuring health equity. The first is disaggregation or stratified reporting, where quality is measured and reported separately within patient groups, like in Black, Asian, and white patients separately. The other approach focuses on measuring disparities, or the difference between two groups, like between Black and white patients. The implied incentives of these approaches are relatively straightforward if patients and policymakers only care about one dimension of equity. However, patients are typically defined by a constellation of characteristics and may experience multiple forms of marginalization that affect their access to and the quality of care that they receive. So it's typical for quality measurement and public reporting to focus on racial and ethnic equity, but also equity due to income and geographic equity and a host of other dimensions as well. We show in this paper that in these contexts, using the standard approaches may not produce the intended results, in part because addressing one aspect of equity, like racial equity, may effectively be in competition with other aspects like geographic equity. We demonstrate this using a simple example based on 2017 Medicare data on colorectal cancer screening in the figure on the next slide. The figure shows how much each of 4 patient groups contribute to various quality measurement approaches. And this is, like I said, just a sort of simple example using these 4 groups. In the figure, the size of the bar corresponds to how much the patient group contributes to the quality score. On the left, you see overall quality, which isn't focused on equity. Next, you see stratified scores for each of 4 groups: Black patients, white patients, rural patients, and metropolitan patients. Next, you see 2 disparity measurements, one for the Black-white disparity and one for the rural metropolitan disparity. In the figure, you can see that most of the focus in the overall quality score is on white metropolitan patients. That's the orange group. You'll also see that among the stratified scores, most of the weight in the rural and metropolitan scores goes to white patients, that's the yellow and orange, and most of the weight in the Black and white scores goes to metropolitan patients. This means that even though the stratified scores are intended to shift the focus to Black and rural patients, as a complement of measures, they actually still favor the larger groups of patients. On the other hand, disparities measurements may have unintended consequences because, as you can see in the figure, they allocate negative weights to white and metropolitan patients. This means that disparities may be improved, possibly at lower cost, by worsening care to these groups rather than improving care to Black and rural patients. Because of this, we propose a new statistical method for quality measurement we call equity weighting, which you see on the right. In this example, the equity weights are designed to incentivize care to Black and rural patients by giving them twice the weight of white and metropolitan patients, respectively. We play out the incentive structure of all these approaches on the next slide, please. The thought experiment here is that you're leading quality improvement for a provider and can focus your improvement on one of the 4 groups: Black, white, rural, or metropolitan patients. Which group would you choose to make a 5 percentage point improvement in cancer screening if you wanted to most improve your score? We found that to improve overall quality the most, one would focus improvement on white patients. Increasing white screening rates by 5 percentage points led to an increase of 4.6 percentage points in the overall quality score. That's what you see in the top left. But surprisingly, we found that to improve the stratified scores as a whole, one would also focus improvement on white patients. In addition to the possibly unintended consequences of using disparity measures already discussed, Incentives accrue unevenly to different disadvantaged patient groups when using disparities measures, which may or may not align with equity goals. We found that focusing improvement on Black patients improved the average disparity more than improving care for rural patients. And a commonly suggested approach, which incentivizes both overall quality and disparities reduction, incentivized improvement among rural patients much more than Black patients. On the other hand, the equity weighting score performs in alignment with its construction to incentivize improvement to rural and Black patients equally. So there's a bunch more in the paper about computation and extensions, but I'll just wrap up here by saying equity weighting gives policymakers the tools they need to ensure that quality measurement is able to promote equity and to calibrate it specifically for their equity goals, rather than letting the incentives follow ad hoc from the measurement approach. We've just given a simple example using 2 racial groups and 2 geographic groups here, but it's easily extendable to many more aspects of equity and is applicable to basically any quality measure currently in use. It never incentivizes worsening care to any group, and it's adaptable to virtually any equity goals. We give an example in the paper where instead of prioritizing Black and rural patients, all patient groups receive equal weight, but could easily be tuned to whatever goals you have. So I'll just end on the next slide. I hope you'll consider these issues when thinking about how quality measurement can promote equity, and I look forward to any questions. Thanks.
Thank you, Dr. Anil. So we have a couple questions from the audience. We're now moving to Q&A, and then we have some other questions. The first question I'm going to direct to Dr. Carey. So the commenter said your presentation was excellent. Currently, the elderly Black population is not a part of the cultural competency conversation. Patient voice, and they go on to say, my parents were a step away from slavery and my grandparents were slaves. Sadly, the elderly Black population has worse health outcomes in all disease categories. How do we improve the health of the most vulnerable?
That's a great question, and one that I'm very concerned about, as my clinical practice is always focused on the care of older adults. One of the recommendations that we've put forth in our paper is amplifying patient and community voice, and that can be defined in a lot of different ways, but as it relates to older adults, if there are AI and machine learning models that are being developed to inform the care of older adults, then from the very beginning of the design of these models, we need to have a patient panel that includes and involves older adults in informing us of some of the things that are most pressing to them. Otherwise, we risk concerns of perpetuating some of the disparities that are really existing.
Thank you. Our next question, actually 2 for Dr. Hernandez-Broussard. So one is related to your slide about the VBAC calculator. So the question is, are all providers currently using the updated calculator, and when was the change made?
Yeah, so I think there is ongoing work by the national medical societies to really rebuild the trust and educate the clinicians about the changes in the calculator and how they can use it. And I believe the change was, it's been a couple years now. I don't have the exact date in mind, but it's been a couple years. So there is ongoing efforts to really rebuild that trust with both the clinicians and the patients now that it is race aware.
Thank you. Another question is, does your paper include a stance on precision medicine as a way for clinicians to stop conflating race with ancestry?
Yes, it does. So we talk about a sort of a move from precision medicine to precision care. Now, precision medicine is really about the genetics of a patient and identifying drug targets based on genetic information for the most part. And we say that there's a real need to move to precision care, which takes into account patient goals, patient's lifestyle, social determinants of health, ancestry is not a piece of that, but I think it takes a more holistic view. So providing treatment that's really aligned with the patient and the patient's community. So I'm not sure if that answers the question entirely, but yes, we do talk about sort of a shift in the way we think about precision medicine.
Thanks. And one more question for you. So since this is a commenter, since the use of AI is exploding in healthcare, and since AI knowledge is specifically derived from past statements, practices, research, et cetera, the risk of embedded race-based inaccuracies and assumptions is huge. Yet another and new frontier to worry about.
Yes, absolutely. And you know, we do learn from past data. And so that is a problem if that data is biased. So what we need to do is we need to think about really working with policymakers and stakeholders to get data that is unbiased, that is more representative, that really is more holistic in view, so that when we do develop algorithms, we have a more representative data set and a data set that does not contain these biases. However, we also must have in place metrics and you know, algorithms that can really understand, test, and measure these biases, acknowledge them, and devise sort of mitigation strategies to address them.
Thank you. And so I think maybe I'll direct this next question to Dr. Anil first. So the commenter asked, could you comment on the best practices for the risks of applying imputed race and ethnicity data in analyses?
Sure. Yeah, I mean, as with any algorithm, it's possible that the imputing race may be imperfect, and that imperfection may be different for different racial and ethnic groups. But it's also possible to quantify based on, it depends on the method of imputation, but it's also possible to quantify how good the imputation is. And if the imputation is good enough, then you can likely bound the whatever bias may be introduced by using the imputation rather than the real race ethnicity category.
Thank you.
I'd like to add just a little to that, if I can, because that's absolutely right, and I agree with the panelists, and I want to add that, you know, the algorithms to generate synthetic data have just really been exploding and are very accurate, and so now, you know, if you have even a small number of patients that represent a particular population that you know are unbiased, there are good possibilities that you can actually generate synthetic data that can better represent that population. So we're getting better algorithms that can be built on smaller patient cohorts. So the future is looking good in that area. But again, as Dennis mentioned, you know, you've got to be wary of what you're reproducing.
So we have about a minute left, and feel free for anyone to answer this question. So could you talk about how you think about using race in research or clinical decision-making generally? When, if ever, do you feel it's appropriate, and how do you ensure that race is not being used as a proxy for racism or some other phenomena? I know this came up at least throughout two of your presentations. And anyone can comment on this.
I'm happy to start. I think there are scenarios, and we talk about this in our paper, where it might be appropriate to use race in an algorithm if you're purposely trying to address structural racism, and really understand where these differences are, so that you can really dig in to understand, well, what is it a proxy for? You know, what are we really trying to model here in these algorithms? But I think it's a case-by-case basis, and each algorithm needs to be thoroughly investigated by a very broad range of stakeholders who understand what's the decision being made, how is the output being used, and what assumptions are we making in this model. So it really takes broad stakeholder engagement.
I'll also say that you do often need to know race ethnicity if you're going to use some of the auditing algorithms to see whether you have a problem with some sort of algorithm that's being used in the wild. It's nice to know at least whether there are going to be differences based on race. And then I'll say also in the quality measurement space, even if race is only a proxy for other things, you don't want differences measured between providers to be due only to some of the social determinants of health that, differences in access to care that their patients experience. And so in that case, often race can be useful just an adjustment for quality measurement purposes.
Okay, great. Well, thank you. We are out of time and there is a lot more questions that have been coming into the chat, but thank you everyone for your enthusiasm, and Eve, a round of applause for the panel. We're going to move to our next panel. Thank you, everyone.
Thank you so much, Andrew and the panelists, for that excellent conversation. We still have 2 more panels to go, but before we move to those, I just want to say a couple of things. First of all, I want to thank the audience for participating with so many questions. I'm sorry we can't get all of them, but it's really nice to see your engagement. Before we move back into the content, I noted at the outset that we prepared about a half-hour video on the subject. We hope you'll take a look at it. It's available on our website. We have a very short trailer that we'd like to show you. It's just a couple of minutes long, a few faces you may recognize from the first segments of this session today. So I'm going to turn it over to Control to run the trailer.
When we talk about structural racism, you have to talk about current situation and the long, dark shadow cast by past structural racism.
When we think about immigration status, it really determines someone's opportunities for employment, their living conditions, their access to health care, and it's a form of everyday inequality.
AI in healthcare is rapidly expanding. Biased data is an example of structural racism in healthcare.
Several studies have looked at how many Native physicians there are. For instance, let's just start with a simple question. Are there Natives who can lead the team taking care of Native patients? And it's not even 1%.
Over 90% of individuals in immigration prisons are now in for-profit prisons. I mean, these systems are mutually reinforcing, really. I don't think you can have mass immigration detention without the mass incarceration system.
We know the things that we've done in the past do not work. So we need to try something different. We need to be bold, we need to be brave, and we need to be better.
So we hope you'll take a look at the full video available on our website. And now I'm pleased to turn to the third panel. We'll have 2 more to go in our session this afternoon. To moderate the third panel, I'm happy to introduce Elaine Kung, Assistant Professor at the University of California, San Francisco in the Division of General Internal Medicine and at San Francisco General Hospital. Dr. Kung was also a HEFT Fellow, a Health Equity Fellowship for Trainees program that we have here at Health Affairs, and excited to have you involved also with our program today. Over to you, Dr. Kung.
Thank you for the introduction. I'm really excited to moderate our panel today. So our panel is going to be on documenting racism, and we've got 4 excellent presentations. We'll hear from Simon Hayter, an associate professor at the School of Public Health in Texas A&M University, Zachary Dyer, who is an MD candidate at the University of Massachusetts Chan Medical School, Milky Vu, an assistant professor in preventive medicine at Northwestern University, and Jennifer Miles, a postdoctoral associate in the Institute of Health, Healthcare Policy, and Age Research at Rutgers University. So to get us started, I will first hand it over to Simon Hayter.
Hi, everyone. I think we're waiting for the slides. There you go. Thank you so much. Good afternoon, everyone. I'm Simon Hayter. I'm a professor of public health at Texas A&M University. I'm here to present my contribution together with Don Moynihan, who is at the McCourt School Public Affairs at Georgetown University, and our contribution to this issue and the briefing specifically focuses on how race and racial perception shape Americans' willingness to accept administrative burdens in Medicaid and the Supplemental Nutrition Assistance Program. Before talking about our contribution more specifically, I wanted to first congratulate everyone involved with this special issue, as well as this briefing on the outstanding work related to this issue and beyond, obviously. I also wanted to thank the great people at Health Affairs who've helped specifically make our contribution much better, as well as the funders who have made this possible for all of us and who also made this accessible to everyone. And then lastly, on a personal note, I would like to particularly thank one of the funders, the Robert Johnson Foundation, who's been a great supporter of my work over time. Next slide, please. If you're not familiar with administrative burdens, we refer to these often as the frictions that people encounter in implementation of public services. So what does that mean? It means, the learning processes, the completing of forms, documentation requirements, and everything that goes along with it. That's what we refer to as administrative burdens. And as I'll talk to you about in a few minutes, these administrative details are not just administrative details. They're really, really important when it comes to public policy making. Indeed, I would personally argue that they're perhaps the most important policy making area when it comes to the U.S. social safety net today. Let me give you first a very brief overview of our paper before going into that. We wanted to learn more about how, as I said, about how Americans think about administrative burdens in Medicaid and SNAP, and particularly how racial perceptions and race play into this. And so we filled out a large national survey. In this survey, we asked respondents a number of questions about 6 policies, things like work requirements, whether people should be required to apply in person or whether they should be allowed to apply online. And we wanted to see, where the burden tolerance related to these policies lie. And so what we found was that Americans' views on these issues differ substantially depending on the policies that we ask them about. We also found, standard public policy explanation that empathy mattered, concerns about the ability to manage burden mattered, whether you're a Democrat or a Republican mattered, and whether you're associated or previously associated with the program matters as well. And so, as I said, these are pretty standard explanations that we often see in public policy making. But we also found that race and racial perception matter, but they did so in nuanced ways. And I'll talk about those in just a few seconds here. Next slide, please. Oh, sorry. I'm already on my next slide, sorry. Before talking about race and racial perceptions and how they shape burden tolerance, I wanted to take some time to convince you why we should focus on administrative burdens and why administrative burdens are really, really important when it comes to policymaking, specifically policymaking to the social safety net today. I don't think we need to convince anyone that's part of this briefing or participating in this briefing that race really matters when it comes to public policymaking, whether that's health related or otherwise in the United States. There's ample evidence from a variety of literatures and a variety of disciplines that tell us that both historic and current policymaking related to programs like Medicaid or SNAP or TANF are deeply steeped in racial perceptions, and public opinion related to these programs is also still to this day very much driven by racial stereotypes, whether those stereotypes are overt or not. But at the same time, most policy scholars would probably argue that the broad outlines of these social safety net programs in the United States are pretty settled by and large. The probability that it will undo Medicaid or Social Security or even the Affordable Care Act in the near future are relatively slim. There's broad public support for these kind of programs in the abstract. And it's also, as we know, very, very hard to change the policy-making status quo through majoritarian policy making in the United States. Next slide, please. And this, where my co-author, Don Moynihan, and I would argue, is where administrative burdens come in, and that's, our contribution to this issue of health affairs. The broad outlines of the safety nets are largely settled. It's really these seemingly mere administrative details that remain malleable and that can have substantial impacts on beneficiaries and potential beneficiaries. There are clear primary effects, obviously. Burdens are crucial tools of public policy because they're major determinants whether Americans are actually able to enroll in public assistance programs. But as we know from the literature, there are large secondary and tertiary effects, including effects on trust in government, self-efficacy, voter registration, and turnout, and all those other things that really matter. And because administrative burdens are still malleable in today's otherwise gridlock policymaking process, and because they're less overt, and because they're so consequential, that's why administrative details, we think, are the battleground for the future of the U.S. social safety net. Next slide, please. And this leads back to just, our study that's part of this wonderful issue on health affairs. I previously told you that administrative burdens are related to race and racial perception, and I'm just going to talk about this one graph here from our study. One of the most substantial findings, the most dramatic findings we had in our study was that non-Hispanic whites with high levels of racial resentment dramatically differed in their willingness to impose burdens on beneficiaries and potential beneficiaries. And as you can see here, the differences are quite massive for public policy making, and it's quite shocking how substantive these differences are. It's worth noting here, though, that not all of our findings related to race were negative. And I think this is where a bit of light comes into this. Respondents who believe that burdens had disparate effects on historically disadvantaged groups were less favorable towards more burdensome alternatives. And I think that's one of the points we can tackle through education. Next slide, please. The bottom line here from a policy perspective, I think, is that it's pivotal that more people and policymakers start paying attention to administrative burdens because they are so consequential and because they're not very overt. I think that's starting to happen. I think work like the work that's included in this special issue is part of moving us forward, and it's really crucial that we continue this path. Thank you.
Then we'll move on to Milky Vu, who will be presenting on food insecurity and SNAP participation among Chinese, Filipino, Japanese, Korean, South Asian, and Vietnamese adults.
Thank you, Elaine. I'm really honored to be here and presenting in this event. On behalf of our co-authors, I will be presenting a study on food insecurity and SNAP participation among low-income Asian American adults. Next slide, please, or waiting for the slides for my presentation to be loaded up. Thank you. And next slide, please. So food insecurity is an important determinant of health and is linked to poor social, physical, and psychological outcomes. One strategy to address food insecurity is through participation in nutrition assistance programs, such as the Supplemental Nutrition Assistance Program, or SNAP. Now, in the US, many people who are eligible for SNAP are now enrolled in the program. And furthermore, research has documented racial and ethnic disparities in food insecurity. However, one critical gap in the literature has to do with Asian Americans' experience with both food insecurity and SNAP participation. So, for example, separate data on Asian Americans are not currently provided in the annual USDA reports on food insecurity in the US. So in this article, we talk about a couple of issues related to this lack of representation. So the model minority myth, the assumption that Asian Americans are homogeneous, all the same, they are socioeconomically successful and do not experience structural racism or health disparities. There's also the tendency in research and policy to subsume all Asian origin groups under one category, even though this category includes people from over 30 countries of origins, speaking over 100 language and dialects, and having diverse immigration histories, cultures, and religious beliefs. Next slide, please. Next slide, please. So to fill this critical gap in the literature, we conduct a study using pooled data from 2011 to 2020 from the California Health Interview Survey. And we look at the prevalence of food insecurity and CalFresh participation, providing disaggregated data for low-income Asians from 6 origin groups: Chinese, Filipino, Japanese, Korean, South Asian, and Vietnamese. Furthermore, we also wanted to see if limited English proficiency was a barrier to CalFresh participation and whether this association is the same for different Asian origin groups. Next slide, please. So our first key finding is that at least 1 in 4 low-income Asian American respondents experience food insecurity. And in particular, around 40% of Filipino adults report experiencing food insecurity. And in addition, we also saw heterogeneity in the severity of food insecurity across Asian origin groups. So if you look at the orange bars here, for example, very low food insecurity affect around 2% of Chinese adults, but 9% of Filipino and 10% of Japanese adults. Next slide, please. Our second key finding is that CalFresh participation is low among most Asian origin groups, with the lowest rates observed among Chinese adults at 11% and Korean adults at 12%. Most Asian origin groups have lower CalFresh participation than what was observed among Hispanic or Latino, African American or Black, and white respondents. Next slide, please. Now, one of the things that we had hypothesized was that those with limited English proficiency might face challenge in understanding eligibility or recertification requirements and navigating SNAP application processes, and thus will have lower SNAP participation. However, we did not find this to be the case in our data. And in fact, when we look at unadjusted analysis, so prior to controlling for covariates, Asian American respondents with limited English proficiency actually had generally higher participation rates compared with English proficient Asian American counterparts. Now, the magnitude of difference did vary across origin groups, which underscores the importance of disaggregating data for Asian origin groups. Next slide, please. Now, there are additional analysis that we have conducted in this paper that we encourage you to read through to get a full understanding of the topic. But for the sake of time, I'll move on to the key takeaways from this study. So we argue that policymakers and practitioners interested in addressing the impacts of structural racism on health disparities among Asian Americans might consider data disaggregation as a first step toward addressing unique needs and barriers faced by specific populations. So through data disaggregation, we found that the highest burden of food insecurity was among Filipino adults. Highest levels of very low food insecurity was among Japanese adults, and the lowest CalFresh participation level was among Chinese and Korean adults. Limited English proficiency was not a barrier to CalFresh enrollment, which might point to the role of California's language access laws, which require translations of CalFresh program materials in many Asian languages. It could also be because of community-based organizations, which often offer CalFresh enrollment navigation assistance, and those with limited English proficiency might use community-based organization services more often than their English proficient counterparts, and therefore might be more likely to be enrolled in CalFresh. And last but not least, given these findings, we believe that one-size-fits-all approaches to food insecurity and nutrition program enrollment interventions might have limitations. And instead, what we need are culturally tailored, linguistically appropriate interventions that incorporate target outreach, consider unique needs and assess in each populations, and involve partnerships with trusted community agencies. Next slide, please. I'd like to thank the stellar team of co-authors, so Zwitrick, Namrata Kandula, Nyatha, Jennifer Magalaski, and Hilary Seligman. Also would like to acknowledge the support of Ellen Bayer, Danita, and Kwang Yoon Kim. I was supported by an NCI T32 grant and complete this study through my participation in the Health Equity Fellowship for Trainees program organized by Health Affairs. Thank you.
Great, thank you for that presentation. We'll move on to a presentation from Jennifer Miles on racial and ethnic disparities in buprenorphine receipt among Medicare beneficiaries in 2015 to 2019.
Good afternoon. My name is Jennifer Miles, as was just mentioned. I'm a postdoc at Rutgers, and I'm honored to be here today to present the results of this work. Next slide, please. And I just wanted to take a moment to thank my wonderful co-authors and to also acknowledge our funders for this work. Next slide, please. Next slide. So opioid use disorder and opioid-related adverse events, such as opioid overdose, are a growing concern for Medicare. Medicare enrollees who are younger than 65 and eligible due to a disability represent 15% of all Medicare enrollees, but 81% of all fatal overdoses among Medicare enrollees. And opioid use disorder diagnoses are increasing among Medicare enrollees who are 65 and older. Next slide, please. Expanding access to evidence-based treatment is essential for responding to this crisis. In 2020, while overall receipt of medication for opioid use disorder was low, as the figure on this slide indicates, white Medicare beneficiaries received any medication treatment, and specifically buprenorphine, at higher rates than other racial and ethnic groups. Buprenorphine is vital for reducing fatal overdoses, as it is less disruptive to daily life compared with methadone, as it can be prescribed in office-based settings, and prescriptions can be picked up at the pharmacy and taken at home. Next slide. Next slide, please. The present study used national Medicare claims and identified a sample of approximately 740,000 beneficiaries who had either an opioid use disorder or overdose diagnosis between 2015 and 2019. Next slide, please. We conducted both national and state level analyses and stratified by both eligibility groups. However, today I will focus the presentation results on the disability eligible population, but you can find results for the older adults in the published work. Next slide, please. We calculated two outcome measures. First was the percent of buprenorphine utilization to understand overall patterns of receipt for each racial and ethnic group in each study year, as well as the ratio of the percent of buprenorphine receipt for each racial and ethnic minority group relative to their white counterparts, which I will refer to as the disparity ratio. Next slide, please. Next slide, please. The figure on this slide presents results for the percentage of buprenorphine receipt for each racial and ethnic group in each study year. Next slide, please. Overall, buprenorphine receipt for all groups in all years was below 25%, so extremely low. And each racial and ethnic minority group had significantly lower receipt compared with white beneficiaries in each study year. Rates were lowest among Black beneficiaries. In 2019, only 9% of Black beneficiaries received buprenorphine compared with 22% of their white counterparts. Put another way, Black beneficiaries' receipt would have to be 246% higher to catch up to white beneficiaries. Next slide, please. Next, we examined annual trends in the ratio of buprenorphine receipt for each racial and ethnic minority group relative to their white counterparts. The y-axis on this figure ranges from 0 to 1, with lower values indicating greater disparities. The disparity ratio was particularly pronounced and persistent for Black beneficiaries, improving only 14% across the study period and did not even reach 50% by the end of the study period. And one notable exception is the improvement for American Indian and Alaska Native beneficiaries, whose disparity ratio improved by 65% and approached parity by the end of the study period. Next slide, please. Next, we examined the disparity ratio at the state level and combined all study years to be able to include as many states as possible. On this figure, lighter colors indicate a greater disparity. And here we see the results for Black beneficiaries. Next slide, please. While we do see some variation at the state level, most states have significant disparities, and 5 states fell into the lowest category, meaning that Black beneficiaries' buprenorphine receipt was below 25% of the rate for white beneficiaries. Next slide, please. And I just want to highlight Maryland stands out as a bright spot, and I'll describe some recent initiatives in that state later in the presentation. Next slide, please. And I also wanted to quickly highlight state-level results for American Indian and Alaska Native beneficiaries. Next slide, please. Well, as we saw on the national level, the disparity ratio for this group was highest, meaning the least disparities for all the groups that we compared. And in 14 states, that actually they met or exceeded parity with their white counterparts, including in states with greater representation of American Indian and Alaska Native people. Next slide, please. So how do these results fit into the wider context of the overdose epidemic, and what might an equity-focused policy response look like? Next slide, please. The figure on this slide describes an evolving crisis. Although overdose deaths were concentrated among white people early in the epidemic, beginning in 2016, we see a rapid increase in overdose deaths among Black people. And as the crisis evolves, so too must the policy response. Next slide, please. If I could sum up this policy response in 3 words, it would be no wrong door. For example, buprenorphine prescribers are concentrated in suburban white neighborhoods. And as I mentioned earlier, Maryland is a bright spot for Black beneficiaries. And this is likely due to efforts by the city of Baltimore to increase access to buprenorphine in non-traditional settings such as methadone clinics and formerly drug-free specialty settings. Similarly, the Indian Health Service recently enacted policy change to increase the use of telehealth services for buprenorphine prescribing. Payers like Medicare could also disaggregate existing substance use treatment quality measures by race and ethnicity to monitor equity in real time. In summary, this is a multifaceted crisis that requires a multi-level, equity-informed response that meets patients where they are. Next slide, please. Thank you so much, and I look forward to our discussion.
Great, thank you for the excellent presentation. We'll turn it over to our last panelist, Zachary Dyer, who will be presenting on measuring the enduring imprint of structural racism on American neighborhoods.
Great, thank you. Good afternoon, everyone. I'm Zach Dyer, and I'm an MD PhD candidate at the University of Massachusetts Chan Medical School. Very excited to be here today. Congratulate everyone and thank Health Affairs for bringing us together. Usually I start most of my presentations with a definition of structural racism and a little background, and it's really refreshing to not have to do that, as everyone has been well informed at this point. I do want to thank my co-authors for this paper, Matt L. Kuski at UMass, Dean Sandra Gallia at BU School of Public Health, and my mentor, Dr. Arlene Ash, who's also at UMass, who's been with me on this journey for years, is really my primary thought partner in how to approach this and the implications of measuring structural racism. Go to the next slide. So we really, in this work, we wanted to measure the effects of structural racism, and it's definitely easier said than done. We wanted to look at the neighborhood level effects of structural racism and really believe that that is where you're going to see a lot of the differences in how racist policies are impacting the social determinants of health. We've heard several times say that we need to do a better job of centering racism rather than race in research and policy, and this work was really an effort to do that. So I want to start with some of our kind of assumptions and hypotheses to this work. And the first assumption is that the distribution of social determinants of health is driven largely by the history of racist policies. I think we often think of structural racism as one of the drivers of the distribution of social determinants of health, and we really approach this as thinking that it's the primary driver, or one of the primary drivers that is really determining why some neighborhoods have access to certain resources and some don't. So our hypothesis from this is that a measure that is built using a structural racism framework will better capture meaningful differences in neighborhood conditions. We have plenty of measures out there to measure kind of the neighborhood resources of neighborhood resources that are available in terms of social determinants of health, but none that are really coming from a perspective of structural racism. Our next assumption is that racist policies have decades-long consequences, and that really should say centuries-long consequences, that the policies that we see, starting with slavery and American imperialism, colonialism, have impacts that have lasted to today, so 400 years of impacts, and that a lot of the policies since have reinforced those. So our hypothesis is that the resources today will follow patterns of long past policies. The next assumption is the area resources available to residents directly influence their short-term and long-term health. That's not one I think I have to explain to the audience here, as we've heard a lot today. And the hypothesis there is that the effects of structural racism will predictably and consistently impact the overall health of an area's residents. And then finally, policy choices today will reinforce the effects of yesterday's policy choices, that the status quo is a very powerful force. And if we don't intentionally work against it, then we're never going to see any change there. Next slide. So there's a long process to kind of create this, the index that we call the Structural Racism Effect Index. We really started by looking at a lot of the different area measures that are out there and looking at the ways that they were measuring the distribution of social determinants of health. Then we turned to the structural racism literature and said, what are all the different areas that when someone says they're going to measure structural racism, what are they looking at? They're looking at segregation, are they looking at transportation, are they looking at these different areas out there? We found that a lot of the structural racism measures were looking at this particular variable or a particular type of structural racism. And we said we want to be able to bring together all of this different information, that structural racism is really many systems reinforcing the status quo. So we ended with 9 domains: built environment, criminal justice, education, employment, housing, income and poverty, social cohesion, transportation, and wealth. A lot of these are consistently in different area level measures. Some of them you don't really see that often. Criminal justice, some of what we have in social cohesion, and even some variables that we pull into other domains like transportation. We found that carpooling is actually a very important measure for understanding the resources available, because it speaks not just to household resources, but also to neighborhood resources. Is there public transportation? Is there, some sort of community built, et cetera? Next. And I'm not going to go into the kind of nitty-gritty details here, but what we did was compare the Structural Racism Effect Index, the SREI, to other commonly used area measures of social determinants of health, including the Area Deprivation Index, the Social Vulnerability Index, and some others. And we wanted to see, how well does our index predict differences in important health outcomes. And what we're looking at here is how well it predicted life expectancy at the census tract level variation in life expectancy across the country. We found that the SREI does a more consistent job of predicting or accounting for the variability or the variation in life expectancy. We also wanted to look across different types of census tracts, so degree of rurality, and then also the ethno-racial composition of an area. So is it, high proportion people of color, mixed area, low proportion people of color? And found that consistently, the SREI was more strongly correlated with life expectancy than those other measures. We looked at a few other health outcomes, which you can see in the paper, but found kind of the same thing, that the accounting for structural racism and coming from that approach made a more consistently predicting index. Next slide. And I just wanted to say that what we really want to see happen is for people to engage in this work, to kind of become thought partners, kind of tell us how we can improve in these different domains of measuring them, and to see this as an iterative process, and to use the data, which is freely available. The website just went up today, so it might still be a little buggy, but my contact information is there. If you want to reach out, we're very happy and eager to be able to work with everyone to see this work move forward. Thank you.
Great. Well, thank you to the panelists for some really excellent presentation. In the audience, feel free to start sending questions. There have been a handful that have come through, so I'll go ahead and get started with some of the questions. The first one is directed at Simon, and one of the audience members had asked, what incentives or efforts are you aware of that have been available to really engage administrators in an effort to modify policy or really reduce sort of some of these administrative burdens to increase equity?
Yeah, that's an excellent question. I think under the Obama administration, in the end, we saw some attention to this, but the Biden administration has really moved aggressively on this issue. And there have been two executive orders that have kind of directed federal agencies to take administrative burdens into account. I think one of the big problems that the Biden administration or any federal effort runs into is that a lot of the important programs that we care about in lifting people out of poverty and making their lives better are shared governance programs, which means they're basically administered at the state level. And what we're going to get is a wide variety of efforts to focus or not focus on administrative burdens in a positive way. I think the public health emergency ending is one of those great examples where we see great diversity in how many people are disenrolled from Medicaid for administrative purposes. So I think we're facing a significant challenge because of the federal nature of this country and the shared governance nature of many programs that is really requires a bottom-up, state-by-state kind of effort to focus on these kind of issues.
Great, thanks. The next question goes to Milky, and it's sort of a two-part question. I think the first is, largely there's a growing effort to really collect more disaggregated, more granular race and ethnicity data in research and also for these programs that Simon has discussed. Wondering if you can just elaborate a little bit more on sort of why, that's so important and what you would like to see race and ethnicity data collection to look like in the future.
Sure, I'm happy to speak on that. So, in the article and in the presentation just now, we touched on, the heterogeneity of the category so-called Asian Americans and sort of the need to understand really data by origin groups. I would say that it is true that, in recent years, with national survey and data sets, there have been a more concerted and effort or awareness around the need to collect data by country of origins for Asian origin groups. However, the collection of data and the reporting of data are two different stories. So, as a researcher who's interested in using national data sets, often I've come into the challenge of, like the survey itself will collect data on whether you or self-identify as Vietnamese, Chinese, Koreans, etc. However, in the public use data file, that data is not available. And the reason given is often because of small sample size and the need to protect the confidentiality of the participants. And usually, in order to access that data, researchers need to request a restricted data file, which then will cost money and involve a more cumbersome application effort, which might deter researchers, especially junior faculty, to be able to access and use that kind of data to make this kind of or produce this kind of research reports. So I think the California Health Interview Survey is one of the few that are representative data sets that collect on a large scale and do provide that granular in data by race and ethnicity freely to researchers. So I would say on the whole, I would like to see more collection of data, but also reduce barriers and burdens in the reporting and provision of these kind of data set for analysis for those who are interested in these kind of questions.
Great. And an audience member sort of had a second question, sort of, I guess, digging a little bit more into really granular data. Folks were wondering if you saw any sort of generational differences or culture aspects that account for some of the differences in use of CalFresh benefits in the AAPI communities that you studied. So again, sort of generational differences or any cultural aspects with regards to specifically honor being a factor as to why folks may not have wanted to sign up.
I just want to clarify, did you say honor?
Yeah, one of the audience members was wondering if honor was it perhaps the cultural aspect that confounded the usage of CalFresh?
Yeah, so really excellent questions. Unfortunately, with the California Health Interview Survey and the variables or measures that they use to collect the data, that's not a question that we are able to answer. However, we do know that barriers to SNAP or nutrition assistance programs often include cultural stigma as part of one of the challenge or one of the reasons why individuals might not want to sign up for the program. We also know that in the US, the discourse around food assistance or nutrition assistance is often very much racialized and play on and reinforce racial stereotypes about so I think that there's certainly the question of stigma and honor, like you mentioned, is important, and it necessitates further research, possibly through qualitative methods or mixed methods to understand more of this problem. There have been a couple of papers I should mention that are out there specifically on this issue among Asian Americans in California. So I would encourage people to go look up and read these papers and do more research on it, of course.
Great, thank you. The next question is directed at Jennifer. One of the members of the audience was just wondering how much the change over time in disparity ratios may be due to differences in white patient outcomes, either worsening or improving over time.
Yeah, thank you for that question. I think it could be, but I believe that, ultimately what we've seen is that receipt of buprenorphine was sort of increasing at about the same rate. And so our sample included, individuals who had some kind of need for treatment. And so, it could possibly be that just the white rates are reflecting that change in worsening, but ultimately we've seen that people are receiving medication or not receiving medication at rates that continue to be disparate.
Great, thank you. And then for Zach, you've created this new index, and it's great that you made it open source and available for folks. Would love to hear how you're thinking, even just some of the presentations today or sort of other work that you have seen. How are you hoping that the research community uses the Structural Racism Effect Index? Are there specific research questions you or your team are currently exploring or would love to collaborate with folks on?
Sure. Thank you for the question. Yeah, I think there are a million questions that I would love to try to answer with the Structural Racism Effect Index, but something that we have looked at on our end that I think would be interesting for everyone is kind of what is the effect on health outcomes of people living in neighborhoods who have really high effects of structural racism, and I think answering that question helps to tell the story of what happens when neighborhoods are left behind and consistently not given the investments they need to achieve good health and other forms of prosperity. Just in some of our tests of the index, we found that emergency department utilization is incredibly correlated with the neighborhood that people are in, and using our index, we could see a pretty stepwise increase in emergency department use across our state. And I think there's looking at whatever data people have available to see what are those effects, and when you're looking to create investments at the hospital level or at the health plan level, or a municipal or statewide kind of governmental level, where are the places where you can invest and have the greatest impact, because that's really what we need to be doing, is figuring out how we have the greatest impact on populations who've historically had kind of the opposite effect when it comes to policy decisions.
Great, thank you. And then Zach, also just another follow-up question that came in. One of the audience members was wondering if you had also considered looking at political determinants of health as well as social determinants of health, and sort of how you thought about that in designing your index?
Yeah, something as you go through and read the paper, there are a few areas where we said, we really wish we had better data. One of them is criminal justice, and it's just not there isn't great data there. The other area is civic participation, and I think that a lot of the political determinants of health should be better incorporated, but we just don't do a great job of I think capturing those as it is. We tried really hard to integrate, voter turnout, voter records, and try to understand kind of how people are participating in their community and what that access looks like. And just had a really hard time, really difficult job of integrating that. I think some states do a better job of others, but I think that would absolutely strengthen our index if we could pull more of that.
Great, thank you. Another question for Jennifer. Your study really focused on the Medicare population. I wonder if you or your team have really looked at or thought about sort of how these studies might differ if you were to look at the Medicaid population, for example, or sort of a different population with different providers and payer mix, I guess.
That's a great question. And we are actually in process of using national Medicaid data to sort of replicate the same analysis. And I want to just take a minute too to acknowledge Pew, because they're one of our funders for this work. And they really had the important foresight to put out an RFP to study across different payer mix, both so for Medicare, Medicaid, and we also have commercial insurance available to us to really try to start digging in these claims data that we know are so rich in many ways and limited in others. But so some preliminary findings from our Medicaid analysis are that while the picture looks a little bit better in terms of absolute rates of receipt for the same racial and ethnic groups that we analyze in this study, rates are still extremely low, below 50%, and this is a population of people with a treatment need. They're diagnosed with either an opioid use disorder or have experienced an overdose. So, it's a little bit better in the Medicaid population, and we're kind of still thinking about why that might be. It's a little bit even better among commercially insured folks as well. But I think by and large, the message is that across all of these various populations, that access is still extremely low, and we're still seeing significant disparities across groups.
Thanks for sharing that. Unfortunate here, but perhaps not surprising that those disparities exist regardless of payer. And the next question goes to Simon. Your presentation is really interesting. As you noted, perceptions are, obviously really hard to change. What do you view as sort of the way forward on this? Do you, is it necessary to change people's perceptions, or really should people just be advocating at the administrative level to change some of these burdens, or what do you view as sort of the best way forward?
Yeah, it's an excellent question again. I think highlighting the consequential nature of administrative burdens is an important part of this. Most people don't really think about administrative burdens as a policymaking tool, but they really, as I tried to outline in our presentation, they've really become really important. We have really disparate take-up rates depending on the level of administrative burdens associated with a specific program or with a specific state that they're in. And so these are really consequential. And I think focusing more on that and bringing that more to light, I think is an important first step, that we really look at administrative burdens as a tool of public policy making. I think then, continue in line with all the research we're talking about related to structural racism and health inequities and health disparities. This is one important component of that, right? And I think as far as we can shed more light on these issues, I think that's important. But as we can also engage policymakers and regular people about these kind of issues to foster more learning on these kind of issues, and that in our case, that administrative burdens are not just administrative details, they have consequences. I think, the learning process, I think here is really important.
Great, thank you. And then the last question here as we wrap up, I'll send it over to Milky. One of the audience members was just wondering if you could expand on the role of different cultural foods and their availability, and if that impacts enrollment in CalFresh at all.
Yeah, I think that's a really important question. And I would say that the way that the California Health Interview Survey defined food insecurity is based on the presence or lack of, food in the household. But we know that food that are socially acceptable or culturally acceptable is another important, very important aspect of this question, and even nutrition or diet quality. So in the California Health Interview Survey, this was not something that was explored, or there was no questions that assess specifically the presence or lack of culturally relevant food. But again, I think this is a really important topic for future research, focusing on, not just the presence or lack of food, but, whether people think that the food that they have access to is culturally relevant to them.
Great, thank you. Well, I really appreciate all the panelists joining us today and really commend your efforts and your publications. And so we'll pass it along to the next panel, which will be focusing on responses to racism.
All right, hello everyone. My name is Jessica Bylander. I am a senior editor and correspondent at Health Affairs. And as Great, now I see. It's just been my honor to work with my colleagues, advisors, and the authors on this special issue of the journal. Our final panel of the day is focused on responses to racism. Thanks all for hanging in there with us, and this is going to be a fantastic final panel, so we really look forward to the presentations. We will hear from Ariel Deutsch, a research scientist at Avera Health, Shakina Fashal-Walters, Assistant Professor in the Division of Health Policy and Management at the University of Minnesota, Chidima Ibe, Assistant Professor in the Division of General Internal Medicine at the Johns Hopkins University School of Medicine, and finally Joel Weissman, Deputy Director and Chief Scientific Officer at the Center for Surgery and Public Health at Massachusetts General Hospital and Professor of Surgery, as well as an Associate Professor of Healthcare Policy. So with that, I will turn it over to Dr. Deutsch for the first presentation.
Okay, awesome. So I guess we can start with the first slide. Hi, I'm Ariel Deutsch. I am a research scientist at Avera Research Institute, and thanks so much for attending this. I'm really excited to talk about the work we've been doing. Next, the article focuses on clarifying processes that can help empower Indigenous community organizations, or ICBOs, to address unmet psychosocial needs through culturally grounded practices that are built on genuine trust with community members. As ICBOs primarily rely on external funding, especially funds that focus on providing services, they have consistent challenges to sustain their work. So next. These findings come from an ongoing community-based system dynamics project, which examines health disparities within a Northern Plains Indigenous community. And over the work, the topic of funding has become increasingly prominent. So that prompted us to focus on clarifying the processes that can really help ICBOs to thrive. The article goes into a lot more detail on the projects and methods, such as the causal loop diagrams shown here, and the operational definitions of the terms we use. And hopefully the brief overview presented here will get everyone interested in reading the article. So next, the article premise is that Indigenous communities want and would benefit from higher capacity ICBOs. However, the misfit between policies for funding provision and how ICBOs can best use provided funds is a barrier for this goal. So the crux of this is that the current policies disproportionately benefit better resource and non-Indigenous, predominantly white-led organizations, which in turn maintains not only community disparity, but also health inequity. Next. At the core of this inequity is a capability trap, in which ICBOs are forced to work harder to survive in a system that inhibits them from working efficiently. ICBOs must seek small grants as a short-term solution at the expense of investing in capacity and infrastructure for long-term improvement. And unfortunately, there are not a lot of other options for many ICBOs due to the external funding dependence. So next, ICBOs often have an operating capacity deficit due to little funding for investment. Therefore, they need more funding. So next, this will increase the effort needed to seek and obtain grants, which next will increase the needed capacity and infrastructure for all operations, which next will increase the deficit. And next, we see how this trap is aided and enhanced by multiple funding policies. For instance, next, direct and indirect cost policies are a key contributor to low ICBO funding for capacity investment. ICBOs must often use the small amount of indirect funds they receive to support necessary activities for providing culturally grounded services that are often not covered by direct costs, especially if direct services emphasize Western evidence-based practices, which need to be modified in Indigenous communities. Next, evidence-based practices often require more capacity than what ICBOs have. Therefore, ICBOs often have to focus on attaining smaller grants with less rigorous requirements for direct costs or for small projects. Next, however, this requires devoting more effort for attaining and managing grants, and the burden of these efforts can become larger than the benefits from the funds themselves. Next slide. But the struggle for sustainability does not just impact individual ICBOs. It has community-wide consequences due to competition. Next. Next once more. First, ICBOs compete with each other for a small pool of grants based on both the size of the grant they can attain and the amount of the grants that they need. But next, as external funders often use service provision as a metric of project success, ICBOs often also compete for clients in a small pool of eligible community members, limited by a narrow specific issue of focus. Next, tailoring projects to meet grant interests increases the risk for service duplication, leading to a consistent churn of unsustainable services, little knowledge of what services exist, and therefore the creation of new and duplicated services. Next, to gain additional resources, we again see the capability trap through subcontracted partnerships between ICBOs and larger predominantly led organizations. Next slide. Awesome. For ICBOs, this is a common quick fix solution that is often necessary for survival. Next. Subcontracts do benefit ICBOs, as ICBOs can utilize the capacity of the larger organization and increase their grant provision, and for research-based grants, contribute to the evidence base for culturally grounded practice as a form of psychosocial care. Next, however, there is little support for the ICBO outside of the direct project, with limited opportunity to grow capacity. And after a grant ends, ICBOs may still not have enough infrastructure to continue service provision as a primary grantee. So therefore, they still remain dependent on subcontracted relationships. Conversely, the larger organization can better demonstrate success to funders and receives a larger amount of indirect funds, meaning they're often in a better position to sustain themselves after the grant ends compared to the partnering ICBO. Next slide. Next. So there are a few ways funders can change grant policies to support thriving psychosocial care ICBOs. Despite increased funding for Indigenous health that has been growing over the past few years, we argue that investing in Indigenous health means restructuring policies to focus on ICBO sustainability and collaborative efforts driven by community leaders. This includes things like modifying direct and indirect cost structures, requiring additional support for sustainability and handoff of services when there's a subcontract, and increasing access to resource sharing and reduce grant barriers to allow ICBOs to use that funding for building infrastructure. Providing larger grants that support efforts for multiple ICBOs to collaborate on planning and implementing new care efforts would reduce the scrambling for next funding stages and would provide a stronger base for equitable collaboration. Next, finally, researchers have generated a lot of information on how structural racism can shape health inequities, but this knowledge doesn't always clarify the specific processes by which this works. And without this, we have little guidance on the best actions to take in order to dismantle these. So future research can move beyond understanding how structural racism explains health inequity to more so understanding how this inequity is maintained, and that is defining the processes that both perpetuate inequity and simultaneously preserve the current power structure. I want to thank all of the different contributors who have given us a lot of information on this, and most specifically the community members who have been gracious enough to share their wisdom, their knowledge, and be collaborators on the actual project. So thank you.
Thank you, Dr. Deutsch. Now we will move to Dr. Bashaw Walters.
Good afternoon, everyone. It is a pleasure to be here and an honor to be amongst the works that are featured in this special issue. My name is Dr. Fashaw Walters, and today I'll be talking about our work entitled Proposing a Racism-Conscious Approach to Policymaking and Healthcare Practices. And first, I'd like to acknowledge my thought partner in this work, Dr. Sydney McGuire, who's at Indiana University. We can go to the next slide. In this work, we present what I might refer to right now as a spectrum of policies that we see. And this spectrum of policies move us from equality closer to equity. Let's go to the next slide. The first policy that we talk about is referred to as a race-neutral policy. Race-neutral policies are also perhaps considered colorblind policies and practices, and they attempt to improve quality for everyone, regardless of race, but they don't consider the inevitable impact that racism might have through policy and through our policy environment. Now, it's important that I note that we don't use the term race neutral to imply that there are no racialized impacts of these policies, but on the contrary, what a race neutral policy intends to do by ignoring race and being colorblind in its actions is quite different from what it actually does, where we see that many of these race neutral policies might exacerbate or at its best, maintain the inequities that we already see. The guiding approach that sort of guides these sorts of policies is that all people are equal, race and skin color do not matter. It really disregards how racism disproportionately structures resources for racially minoritized communities. It has the ability to exacerbate disparities, as I said earlier, and it focuses its attention on non-racial issues, ignoring the role of racialization in existing disparities. Let's move to the next type of policy. The second type of policy that we talk about on the next slide are race-based policies. Race-based policies and practices are intended to improve outcomes explicitly for people from racially minoritized groups. And this is in contrast to a race-neutral policy. And the guiding approach here is that for those historically disadvantaged groups, race was used to create disadvantage. And the thought here is that now race can be used to provide an advantage. However, these policies can be seen as politically and socially divisive. Whereas they address racial discrimination, they don't address racism, which we know is the root cause and the source of many of the racialized inequities that we see. They, again, elicit sort of negative attitudes from social and political corners, and they really don't fully address all levels of racism by simply addressing race. As Audre Lorde has said, the master's tools will never dismantle the master's house. So we can't use race to dismantle this house of racism or racialized inequities, but perhaps we can use racism in our policies. So let's go to the next slide. Racism-conscious policies and practices consider the role of racism in policy choices, whether that's design, implementation, evaluation, or impact, and it also considers the role of racism in the policy environment that we are creating these policies in. I should also pause to say that we created this framework not just for federal big P type policies, but as we say in the title, we also focus in on practices as well, or small P policies. We can go to the next slide. So this racism-conscious health policy framework that we propose here lives and is based on the public health critical race praxis, as well as the racial equity and policy framework. There are two foundational principles to this policy. The first is to engage and center the communities and voices of marginalized groups throughout this policy creation process. The second is to conduct continuous and ongoing evidence evaluation and policy analysis to understand the impact of the policy throughout each step. We highlight 5 steps in the creation of this policy, this racism conscious policy. We share that the first step is to examine and identify inequities. The second step might be your starting point. It's where we identify inequity related policies. And the reason I say that this could be your starting point is because maybe you've already identified a race neutral policy that exacerbate disparities. Then we would want to start in this step to understand what that policy is doing. Then we go deeper in step 3, where we dissect the policy mechanisms to understand how that policy is operating. And we also want to use that step to look at both the unintended as well as the intended consequences of the policy. Then in the 4th step, we elucidate the impacts of racism. This means naming racism, naming the levels in which we see racism operating, whether it's an individual level, a structural level, an institutional level. And then from there, with that information, we can move on to step 5, where we'll go into creating the racism conscious health policy. Now, the important piece here is to recognize how we implement the policy. In the earlier steps where you identify the mechanisms of the policy, what will become clearer is that a lot of times the ways in which we implement a policy impacts the mechanisms through which racism operates. So that is a very brief synopsis of this racism conscious health policy. In the paper, we also provide an example of what that might look like in reality through a case study. And I'm looking forward to having more conversation with you all about how we can change how we craft policies to better advance health equity through these racism conscious policies. Thank you.
Thank you, Dr. Fesha-Walters. And next, we'll hear from Dr. Ibe.
Thank you. Good afternoon, everyone. It's such a pleasure to be here, and it's really an honor to be able to talk about the study that we conducted in collaboration with the Maryland Community Health Worker Association. My name is Chidima Ibe. I'm an assistant professor at Johns Hopkins University, and I'm sharing this study on behalf of my wonderful colleagues who are co-authors on this endeavor. Anika Hines, Nico Dominguez Carrero, Shannon Fuller, Allison Trainer, Tiffany Scott, Deborah Hickman, and Lisa Cooper. So thank you for your attention, and also thank you to Health Affairs for uplifting this work. Next slide. So to begin, what we conducted was the Amplifying the Lived Experiences of Community Health Workers, or the ALEC study, which is a community-based participatory research study that really strove to focus on community health workers and to situate how their work influences and then is influenced by their own intersecting identities as racially and ethnically marginalized communities. And we were really guided by a few key objectives. We wanted to explore their lived experiences and their own encounters with social risk factors, bearing in mind that they're members of the same structurally disadvantaged communities in which they work. We also wanted to illuminate the ways in which their personal experiences affected their approaches to intervention provision. And then we wanted to learn from community health workers themselves how their intersecting identities affect how they're perceived by the people they work with and the community members that they support. Next slide. So to achieve this, we used photo voice. And photo voice is a participatory research method where study participants take pictures of their local communities and they discuss these images as a group. And these discussions really seek to explore communities' needs, strengths, and capacity for social change. In our study, we used a structured set of questions, which is in the light blue box, through the SHODE framework, SHODE being an acronym where each letter stands for the specific question we used in our discussions. We conducted this study from March through July of last year, and we had 16 community health workers participate. We divided them into groups of 4 cohorts who met once a week for 5 weeks, and we would go over each of the pictures they discussed using the SHODE framework as the basis for these discussions. Next slide. So when we transcribed the photo voice discussions and analyzed the discussions themselves, one of the things that really stood out was the impact of structural and interpersonal racism, which really emerged as the overarching theme across all of the sessions and cohorts. And community health workers spoke about how these forces shaped their personal and professional experiences, as well as the distribution of adverse social determinants of health in the communities in which they work. We saw 4 interconnected themes come out that spoke to how community health workers sought to navigate structural and interpersonal manifestations of racism in their own lives and in the lives of those they're supporting. The first theme being structural racism as a contributor to their own experiences with social risk factors and social needs, their socio-emotional connection to clients and work as a driver of their approaches to intervention delivery, their perceptions of the limits and weaknesses of prevailing social risk factor interventions, and then the unique occupational hazards they experience as a result of being community health workers and occupying the social identities that they have. Now, for the sake of time, I'm going to highlight a couple of these themes, the first and third one. Next slide. So this first theme has to do with community health workers' experiences with social risk factors and social needs, their own social risk factors and health-related social needs, as well as those of the community members that they supported. One of the sub-themes that came from this particular theme is the role of structural racism in shaping concentrated deprivation in Baltimore City, which is where the study was based, particularly the areas of deprivation that are characteristic in Black and African American communities. The community health workers actually ascribed the prevalence of concentrated poverty and other social risk factors to the legacy of redlining and other discriminatory housing practices in terms of shaping things like food insecurity, poverty, and generally speaking, systematic disinvestment. The image that you see here actually speaks to both of these things, not only in terms of how community health work, this particular community health worker described the city, but also highlighting how their neighborhood had a supermarket that was taken away and replaced with a library, and the real implications for their own well-being as a result of that decision. Next slide. Then the other theme that emerged as a result of our analyses was this unique understanding and nuanced understanding of the limitations and weaknesses of prevailing public health interventions that are striving to address health-related social needs. So study participants really discussed the idea that systems and practices were instituted by individuals that frankly betrayed a profound lack of understanding of people's everyday lives, and that public health or other service delivery programs were really marked by a focus on individual level issues rather than the structural roots from which these issues emerge. This image really speaks to this tension between the structural antecedents of social risk factors that community health workers recognized and their attempts to address them from a policy perspective as well as through direct support. Next slide. And so as a result, we had 4 main recommendations. And for the sake of time, I won't go through all of them, but I hope that you will take the time to read the report. I do want to address the fourth recommendation, which was related to funding and compensation. What we found through what our community health worker participants expressed was that the patchwork nature of the funding landscape for community health worker programs really operates in conjunction with their low compensation to affect their own experiences with various social risk factors. And so one of the things that we suggested as a part of this recommendation was to generate that states and the federal government generate a portfolio of sustainable financial arrangements for community health worker programs, with the understanding that in doing so, it would benefit a workforce that is predominantly racialized and minoritized. Next slide. So I just wanted to acknowledge our wonderful study team, which includes a community health worker, and without whom this work would not have been possible. And next slide. And I also wanted to thank the ALEX study participants. Actually, my background is a picture from the Photo Voice project taken by one of the participants. I also wanted to acknowledge and express my gratitude for the Maryland Community Health Worker Association, the Johns Hopkins Center for Health Equity, both faculty and staff, and the National Heart, Lung, and Blood Institute, who helped support this study through a KO1 award. Thank you, and I look forward to further discussion.
Thank you, Dr. eBay. And finally, we will hear from Dr. Weissman.
Hi, everybody. My name is Joel Weissman. I'm a health policy researcher at the Brigham and Women's Hospital in Boston. I'd like to acknowledge support from the Commonwealth Fund and the contributions of my co-authors, without whom this work would not have been remotely possible. I'm really delighted to take part in this event among so much incredible work and so many incredible scholars. Of course, I want to especially thank those of you in the audience who have stuck it out till the not so bitter end to hear this final presentation. Most of you listening are probably aware of the role of DEI officers, diversity, equity, inclusion, and belonging, that exist in various organizations. In the past, most hospitals have addressed DEI by focusing on their internal HR processes, like employee hiring, compensation, and other compliance matters. But with the onset of COVID and the death of George Floyd, hospitals began paying more attention to health and healthcare disparities. So whereas the D and the I are more inward-facing about the internal culture of the hospital and human resources, the E for equity is about reducing health disparities among their own patient population and the surrounding community. The position of equity officer has gotten supercharged, if you will, in the last year or so, with new equity standards from the Joint Commission and with the new attestation-based structural equity measures from CMS. So these positions are really starting to take off. The gap in research that we saw was that very little was known about the people filling these positions. And so our goal was to understand the scope of their roles, including their priorities, facilitators, obstacles, and the skills necessary for their success. Next slide. To do that, we worked with the American Hospital Association to conduct a survey of equity officers in U.S. community hospitals, and then we performed 26 one-on-one qualitative interviews with a propulsive sample selected on purpose. Not every hospital has an equity officer. So this slide shows there are 5,178 hospitals in the AHA database. And based on other information, we estimated that potentially there are 1,179 equity officers that existed at the time of the survey, of which 340 responded to our survey. And then you can see we did, from those, we selected 26 in-depth interview participants. And although we asked a number of questions about equity officer activities, racism has clearly been a topic of elevated interest. And so I now want to summarize just a subset of our key findings, first describing some of the obstacles faced by equity officers in accomplishing their goals, and second, describing some of the policies they're taking to address structural racism in healthcare. Next slide. On the left-hand side of this slide are three obstacles related to racism that were reported by our respondents. The blue and yellow bars represent the number of respondents citing major and minor obstacles, respectively, and the red bar represents those who did not perceive an obstacle. Adding the major and minor bars together, 53% of respondents reported obstacles due to institutional or structural policies that intentionally or unintentionally purport racism. 52.6% reported obstacles due to racist beliefs by people in the hospital or health system, and 65.4% reported obstacles due to the lack of a diverse staff. So the survey gave us a sense of how common these problems are, but not really about what's behind the numbers. For that, we relied on our individual interviews. And for example, if you look at some of the exemplar quotes on the right-hand side, one person said, "This racism has been intentionally embedded into the healthcare system for hundreds of years. It's an uphill battle." Another person stated, "My job is to help people recognize bias. You can't get rid of the bias, but if you recognize it, its impact on your behavior and your response can decrease." And the third person said, "A lack of diversity was probably my biggest obstacle. Just working with a big population of people who don't look like me and who are, I don't want to say afraid of me, but afraid to offend me." Next slide. In my last slide for today's panel, we summarize some of the policies that hospitals are pursuing to combat racism. 54% reported collecting information about instances of racism within the hospital. And by the way, that went both ways. That was about providers having racist attitudes toward patients, and also patients having racist attitudes towards providers. Maybe they didn't want to get treated by certain types of providers. 66% reported forming community partnerships to improve health equity, and 22% reported that their organizations were reviewing clinical algorithms for evidence of bias. Obviously, that could be a lot more. So on the right-hand side, we display some of the representative policies reported by our interviewees, including the creation of reporting portals, forming community collaborations, and so on. Next slide. So in closing, I want to just emphasize that our work here was not intended as an evaluation or a critique of hospitals and their equity efforts, but rather to provide an early glimpse into what their experiences are, especially with respect to addressing racism, both within and outside their walls. Hospitals are facing increased pressure, and they are, a major actor in communities. They're a major employer, they're a major purchaser of services, and they're facing increased pressure to address racism in all its forms. They exist in a wider environment, though, and they have to take into account a vast array of stakeholders, including other institutions, policymakers, and of course, members of the community, all of whom act together or separately to produce policy structures. In this work, we took an organizational perspective to try to understand how equity officers and the institutions in which they sit are responding to these pervasive issues. We learned that collaboration and transparency are key, but equally important, we got the message that equity is never a fully achieved target, but rather an ongoing and iterative goal to be pursued for the foreseeable future. Thank you very much.
Thank you all. Thank you so much for your presentations. I have a number of questions. We have some audience questions coming in, so please continue to add those and I will receive them. So I'll actually start with an audience question. This will be for Dr. Ebay. So they mentioned that California is engaging in efforts to expand the community health worker workforce in multiple ways, particularly using Medicaid. But there's very little intentional planning being put forth to address the unique challenges of this quote unquote racialized and gendered workforce. So nor are the connections to community-based cultural practices being uplifted, particularly as training and curricula are being developed. So what would your recommendations be?
Well, thank you. That's an excellent question. And I've actually thought a lot about what is happening in California and lessons that can be learned from the experience that they've had in terms of trying to get Medicaid reimbursement for community health worker-led services. I actually completely agree with what that individual said in their question. And that's probably one of the threats to the crux of what makes community health worker initiatives so effective is the fact that a lot of the training is done in a manner that doesn't necessarily acknowledge the personhood of community health workers, their specific backgrounds, and the context under which they're living and working. And I think I don't quite have a full answer to that or a full solution to that. I do think that one of the recommendations that we posed, that community health workers be uplifted as experts within these types of initiatives, that is a practice that I think can help mitigate the impact of some of the other things that question addressed, in the sense that, community health workers, because they have navigated these various circumstances themselves, and they've helped other people to do the same, they are the experts in knowing what best practices should be present, but they're also experts in knowing what kinds of training and supervision and supports they require from an institutional perspective to help them thrive. And so, absent any attempt to try to do anything related to community health worker compensation, supervision, anything happening on the organizational level that occurs without community health workers' express leadership is an undertaking done in vain in a lot of ways. And I think this study affirms that, but I think other work that's been done by the National Association for Community Health Workers, state level CHW associations, they also really underscore the centrality of including, or not even including, uplifting and centering community health workers in the forefront of anything related to what they do. So I know that's not the perfect answer or perfect solution, but it's just to say that I think in many ways what is happening in California is something that many other states should be very careful of seeing and learning from.
Thank you. For Dr. Deutsch, you've shown through this, very innovative community-based project that funding policies are a mechanism of structural inequity and racism. And earlier, Dr. Yerby talked about how law could either perpetuate or dismantle structural racism. So I'm wondering what it would look like if funding policy instead were used as a tool for dismantling structural racism.
So the funding mechanism, it's interesting. I'm wondering, and maybe that can be clarified. Do you mean that the funding policy itself is used to implement new policies for structural racism? I guess I don't understand that.
How funding could be used to dismantle structural racism instead of the current status quo where it sort of perpetuates it.
Well, and so that's kind of what I tried to discuss in the article, are different ways in which we really can reduce competition between different small ICBOs, and more importantly, the way that we can utilize a lot of different definitions for what it means to provide effective services, what effective services are. Usually we're defining that through evidence-based Western practices. And I'm speaking specifically about psychosocial care, which a lot of the understanding of psychology and the effective practices to improve psychology is based on a lot of clinical definitions that are very narrow and are at odds with how a lot of other cultures and communities really think about health and their psychological and their holistic well-being. And so really trying to be more flexible in what we consider the important aspects of effective care and how we assess that, I think are ways that we can really reduce what we're seeing right now.
Thank you. Our next question comes from the audience for Dr. Shekinah Fashal-Walters. So how can we engage local policymakers, such as mayor's offices, the city government, in the adoption of a racism-conscious approach to decision-making? What comes up for me is the discussions today about sort of a reluctance to name racism and how you operate in that environment as well.
Yeah, that's getting increasingly difficult. So thanks for that question. To really name racism is becoming more and more difficult in some ways, but also a little bit easier in some ways. I'm really hoping that this sort of paper and this sort of approach, as people take it on, will push folks on a local level to really start to engage the community more. And I think as they engage the community more, then it will be easier for them to be able to name racism for what it is in policies and in actions. You know, we give a few practical steps, especially at the local level, of how to engage community. And that could be anything from providing childcare for those who come to those city meetings that happen at the oddest times when you have children and folks to care for, or even making those meetings more accessible in other ways, whether it's virtually or at different times where folks could make them. So we talk a bit about that in the paper, and I hope that helps to address it a little bit.
Thank you so much. And I've received word we can ask another question or two because we don't need a ton of time to wrap up. But so I'll ask a question for Dr. Weissman, a combination of an audience and my own question. The question from the audience is, do you know of any data on hospitals collecting data on the impact of implicit bias training on patient care? And then my sort of question is continuing with, you know, implicit bias and other training as individual level solutions versus, you know, structural solutions, as we know that structural racism also requires structural solutions. So sort of the weight put on, you know, individual interventions such as implicit bias training and how, and the impact of that, and then sort of how these equity officers are weighing more structural interventions.
Right. So remember I said that equity was kind of the middle part of the D and the I, but that there was an overlap. There's a Venn diagram. And so the implicit bias training really has to do with the staff and the providers. And so that's important. It's not so much what equity officers are focused on, but it's an important part of reducing disparities. And certainly we've heard from equity officers in the interviews and in other venues that implicit bias is an important part of their HR interventions. And you know, it's just, this is I hate to use it's a multifaceted problem, right? You have to get at it from so many different angles, and certainly that's part of it. And so I think implicit bias is certainly on the minds of the equity officers that we spoke with. Many are instituting those policies, but in many cases, for reasons that people have raised here, it's not so easy to do that.
Thank you. And then another question for Dr. Ibe. In conversations around this topic, I've heard a lot about the need to change how we conduct research so that communities are partners and co-creators of the research rather than sort of subjects or even just data points. And so you use the term participatory research. So can you say more about how you conduct research and ensure the community is involved in co-creating knowledge and also benefiting from it?
Sure, that's a great question. So I'll just use this study as an example of how we really try to involve community health workers. So this study actually, the genesis of this study was really years in the making. I've been working with community health workers for several years, and I had heard community health workers share about issues that they had getting access to the kinds of services that they were helping other people try to seek. And so I floated the idea of, I'd love to do something that focuses on CHWs themselves to other community health workers that I've had the privilege of knowing and working with. And then over the course of time, I became acquainted and then friends with the president of the Maryland Community Health Worker Association, who's actually a co-author on the paper, Ms. Tiffany Scott. So Tiffany and I had been thinking about this opportunity for a while. And part of what helped spur it into action was an accompanying project being done within the Center for Health Equity that focused on community health workers, but from an artistic perspective, done in conjunction between the director of the Center for Health Equity and a photographer. So in terms of trying to ensure that CHWs were involved in the research process itself, when we put together some of the ideas and the questions around the study and the interview guide, that's also another piece of this broader ALEC study enterprise. Tiffany was involved in coming up with the questions, reviewing the questions. We had other community health workers who played a role in just sharing their thoughts on the validity of the idea itself. And then the value of the photo voice process is that the images and the captions and the things that are said are coming from the community health workers. And what that allowed us to do is to really sit back and ensure that we were making the playing field between the researcher and those who are participating in the research equal, which I think is really critical for a workforce that, as was previously mentioned, is, primarily made up of minoritized individuals who have had their own histories with research and with the healthcare system. And so we really tried to ensure that community health workers were involved every step of the way, not only in terms of the actual conduct of the study, but also the development and execution and analysis of the results.
Thank you. Well, with that, we will wrap up. Thank you to our panelists for your thought-provoking presentations. Thank you to the audience for your questions and to everyone for this rich discussion. I will turn it back to Alan Weil to close out the event.
Thank you, Jess. And a reminder that Jess was the lead editor on the issue and so played many roles in making this happen. I just want to close us out very briefly. Thank you all for your participation. Remind everyone that the video of this event will be available within the next couple of days. The slides are already posted on our website. Feel free to share those. A reminder that the issue itself and this event are just part of a broader spectrum of content, including the video, the 30-minute video that you saw the teaser of in the center, as well as photographs and artwork. There are 2 narrative matters pieces in the issue as well. A great deal of content for you to engage with around this topic. I want to thank all of our presenters, our issue funders, the Robert Wood Johnson Foundation, the California Wellness Foundation, and the Episcopal Health Foundation. They supported the issue and all of the work that we're able to share with you today. Our theme advisors, Rukiah Yerby and Gilbert Gee, who were in the first panel, who helped us navigate all of the content here. Our commitment to this topic extends well beyond this special issue. We will continue to publish in this area as we have, and we'll continue to expand our understanding of the topic. Dimensions that were raised today, we'll want to continue to explore. So all in the community, please look to us for additional content. And now, thank you again for joining us for this long symposium, and hope you'll take a look at the articles that are in the issue, share the video with colleagues, and with that, we are adjourned today.